Welcome back to the endovascular approach to the treatment of the thoracic aortic pathologies session. I would like to introduce our co-chairman, is Dr. Bun Prasit Kritpacha from Songkhla Nakharin, and our panelists. First is Dr. Parinya Lilayana from Rama Tibadi Hospital. And the second one is Dr. Angsu Chat Rangsan, cardiothoracic surgery from Siriraj Hospital. This session will be 1.5 hours, and we have 6 speakers in this session. So I would like to start with the first topic. May I introduce Dr. Wasin Buttali. He's a well-known cardiologist at King Chulalongkorn Memorial Hospital. His talk today will be the evolution of TIVA in Thailand. Dr. Wasin, please.
Thank you, Mr. Chairman. Thank you, everyone. Let me have my slides. I'm not so sure why I'm here or giving this talk. Feel kind of out of place, but I'll see what I can do. Okay. I was at the beginning when TIVA was started in Thailand. See, I'm still confused between TAVI and TIVA in Thailand, but right now I'm not involved with it that much. Here's my disclosure. First of all, I would like to acknowledge the names on this slide. I kind of cut my old slides and then paste it on my new slides. This is from my earlier talk years ago. This is a team that we started off TIVA together at Chulalongkorn Hospital, involving a group of cardiac surgeons, interventional cardiologists, radiology, vascular surgeon, anesthesiologist, cath lab, and OR team. And I would like to acknowledge in particular Dr. Kittichai Leungtwibun, who probably should be up here on the stage giving this talk. But he's kind of sitting comfortably down there, enjoying listening to what I'm going to say. And I'll tell you a little bit why. This is, when I was asked to giving this talk, I asked myself, well, should I be doing this? And so I have to go back and look at my hard drive to see what I have in stock. And I realized that in my document, I have one folder called stent graft, another folder called stent graft Cine. And there's a lot of them in there, so many. And one folder in particular called EVA lecture, okay? And that in EVA lecture, there's also a lot of contents in there. And I enjoy going through it very much because I forgot all of them. I forgot that I had giving all these talk. But anyway, since the title is how TIVA started, the evolution, this is from my earlier slide. First EVA was performed at Raviti Hospital in 2000, and first TIVA was performed at Chulalongkorn Hospital in June of 2005. Whether this is correct, accurate, I don't think that's important, okay, who's doing first. But anyway, it's happened around that time. And this is the first workshop we held at Chula, and that was October 2004. I can't remember who was our guest, but we did some live case and some audience locally. I think it might be Dr. Franz Moore. And as you can see, we have the heart team 18 years ago. Okay, the heart team didn't just happen after TAVR or between PCI and bypass. This is the second workshop a year later. And I can't remember, I was accumulating all this data back then. And so TIVA started here in June of 2005. And after TIVA, we started doing TIVA. The cases of endovascular repair, including TAVR and SAVR, and TIVA and EVA dramatically increased. And as you can see, the pathology down here, the majority back then was still abdominal aneurysm, but we start seeing some thoracic pathology. Then the third workshop was held in a year later, about 9 months later. Number of procedures increased from 22 to 34. And then if you could see the ratio of thoracic increase and become the majority of cases. Then the other thing I want to point out is that reimbursement for stent graft did happen from the very beginning. And that's why all of you enjoy the luxury of being able to do whatever you want to do to any patient from any of the reimbursement scheme for the last 18 years. Okay? And I'm one of the person involved with having reimbursement possible back then. Because the Heart Association asked me, what should we put in the reimbursement scheme? So I put everything I know, everything at the market price, and that still holds through it. But things will change, and I will touch upon that at the end of my talk. Then in 2007, we didn't have any workshop. The fourth workshop was 2008. Number increased to 65, and now you can see the main pathology now is thoracic, TIVA. So this is why we had to have collaboration. Back almost 2 decades ago, there was no cardiac surgeon with endovascular background. We had a few vascular surgeons with endovascular background back then. One who sit upon the stage, Dr. Bun Prasit. At Chula, so we team up between cardiac surgeons and interventional cardiologists and did it together. Okay. Initially, EVA was done in the OR, but then TIVA was done in the cath lab because we couldn't do it in the OR table, which has the metallic beam on both sides, and the LAO projection was not possible. Until we had a proper OR table, then we moved the procedure back to the OR. And it was all, surgical cut down back then. And this is why we need to have a collaboration because our surgeon back then did not have a lot of background in terms of catheter and guide wire handling and skills, endovascular background. So we had to do it together. And so I did it with Dr. Kittichai for quite some time. This is our earlier case in the cath lab. Dr. Jun right here, Dr. Support here, and so many people make my cath lab very crowded back then. And this is me and Dr. Kittichai, Khu Hu Duo. Oh, this was when we were able to do it in the OR with the C-arm though. So there was no hybrid OR back then. Okay. A simple, I use the title The Ruler. I don't know why we use the ruler. I think we used to use the ruler when we did the AAA way back then. But then we put the ruler as well in the thoracic, although we had the marker pigtail up there. So it kind of tells you how long ago this was, okay? And with the cath lab, we didn't have any digital subtraction, so as you can see, this is all we see. As you can see, this is confusing, the pointer. The subclavian was not ligated or occluded. We left the subclavian open then, that's okay. This is what you can call it a hybrid. An arch aneurysm, huge. And then Dr. Kittichai did a open arch repair. And then we continue on with the TIVA of the aneurysm started from here down, okay? Back then it was a talent graft with, when we opened the proximal end, it's like a windsock. The blood cannot go through. We have to lower the blood pressure, and then we have difficulty trying to kind of position it. It's not like the system we have these days. But back then, there was so many things that we did. Today, I think you guys call physician modify something the graft. We also did. We took the graft out and reverse it and try to put it back in the delivery system so that the open or the free flow will be at the bottom, mark the celiac, and make sure that we're not covered the celiac because we have a limited landing zone, distal landing zone. And so this is the end. I don't think we need to do it, but since we saved the celiac anyway, even if we didn't reverse the graft. But anyway, that was the example of some of the fancy things we did back then. The hybrid debranching surgery was done ever since 2006. This is aortic by carotid, and then followed by zone zero landing TEVA. This is the chimney. I'm not sure we started in 2010 or not, but this is some example from back then. And then we had some of these workshops, having some of the people who want to train in TEVA came to Chula, a small workshop, initially with my with picture of me, Dr. Kishai on there, and then we decided, well, it doesn't look that good. So we took it out and having the pictures of the team instead. Okay, we did it for a few times and then we stopped doing that. But then, you know, the workshop become more and more advanced, but that was back in 2014. So since then, this is my last 2-3 slides. The numbers of TEVA in Thailand increased dramatically, okay, as you can see here. In 2020, it was 419. This next slide, although it's in Thai, but this is a slide from the National Health Insurance, the largest payer, 30 baht program. This is in the cardiovascular device reimbursement. It's the largest expense of all the other, followed by bone and joint, and then IENT. So we almost 50%, okay? And this 47% of the expense, number one was balloon catheter, Corey balloon. Number two is drug-eluting stent. Well, drug-eluting used to be number one, but you know, they did something. And I don't want they to do the same thing with your stent graft. But stent graft now is number 3. And when you look at it, the number of device up here is 40,000, 60,000. But stent graft is only 1,000 out of 400 something case. But it's, each piece is expensive. And if you look down further to more, this is peripheral stent graft. It's number 5. So, you know, they did a central procurement of purchasing of our drug-eluting stent. Our drug-eluting stent now costs almost less than the balloon. We use like drug-eluting stent that other countries no longer use for our 30 baht patient. Not just one generation back, but going back 3 or 4 generation drug-eluting stent. So if they started to move down here, you may face the same problem. The other thing they did with our coronary procedure is that they start to suspect that we overdo the procedure. Maybe we didn't do the, you know, stick to the indication. So they start doing the auditing. And now it's pre-audit. You have to submit something before you can get reimbursement. The same thing may happen to stent graft. So I would end up like this. So TEVA has expanded dramatically in the last 2 decades. The disease, and that's because the disease was malignant, and surgical requires skills and still with high morbidity, mortality, and that's why TEVA becomes so attractive. And TEVA has been fully reimbursed from the beginning. And now we have endovascular trained cardiac surgeon and vascular surgeon everywhere. At the same time, knowledge or evidence has been accumulated. We know more which pathology should be treated or should not be treated, with which treatment, with which modalities, and when. And so does how to prevent and treat complications such as spinal cord ischemia. And the technique and the device has been advanced. So I think if you want to enjoy the luxury of having this less invasive technology to treat your patients, you have to try to not abuse it, because the audit and the restriction in price and how we do the procedure will follow. Thank you very much.
Thank you very much. It's always amazing to attend lecture from Dr. Vasin. At least one thing we can see, the pioneer spirit. He's always at the forefront of the new technology back then, even now, still. And I think the status of the endovascular therapy in the country, in Thailand, is here, owed a lot to Dr. Vasin, to Dr. Kittichai. We all get beneficial effect from the hard work that they are doing. They did back then, and they're still doing by now. And I think the great message for all of us is that we do the best we can do, but don't abuse it, because there are costs that all of that from the taxpayer to help the patients. So we have to be alert and make sure that we do the best. We will continue with one of the big problem that we face in Thailand too, the problem of the blunt thoracic aortic injury. Dr. Kritiya Kiran from Chulalongkorn Hospital will share with us the surgical and endovascular repair for the blunt thoracic aortic injury. Dr. Kritiya, please.
Thank you very much for the introduction, and I'm kind of grateful that I'm speaking after Dr. Vasin, because my slide is kind of continuous from his lecture, from his speak. So my topic is surgical and endovascular repair of blunt thoracic aortic injury, and have some disclosure. Being a surgeon, as you know, is a full-time job, and you need full support from your family. So thank you, my family. And doing endovascular procedures, you need high-quality fluoroscopy and angiographic equipment is essential. So at King Chulalongkorn Memorial Hospital, we're lucky enough to have this hybrid room since 2017, and it was up and operating in November 2017. Okay. And you can't imagine what have we been doing before 2017. We had to use 2 surgical beds connected together using a C-arm, doing a case, especially fenestrated case. We did it for 3 or 4 hours, and the fluoroscopy overheats. So it's in the past now. But I know some other hospitals in Thailand still using the system, which is a pretty good system and is doable. So before the pandemic, in 2018, we have been doing pretty, not much cases. EVAR, about 50 cases a year. FEVAR, almost 10 cases a year. And we still do open surgeries, about 17, 18 cases a year. And TVAR, usually, in the early days, my teacher, Ajahn Kittichai, he's done a lot of TVAR. The number is almost 100, but since he has retired, the case has dropped down, and the cardiothoracic team and vascular teams kind of share the cases. So, like Dr. Vasin said, in Thailand, I would like to let the audience guess how many EVARs we perform in Thailand. It's a kind of a guesstimate number, but it's pretty close. I think about 2,000 to 3,000 cases per year, EVAR. So back to my topic. A 46-year-old male patient involved in a motorcycle accident. Upon arrival at the outside hospital, his blood pressure was 80/60, his pulse rate is over 100, his Glasgow Coma Scale score was 12. So the primary survey and secondary survey found that the patient had bilateral hemothorax, had left intracerebral hemorrhage, had blunt thoracic aortic injury, open fracture of the left tibia and open fracture of both bone, and left forearm. So they intubated the patient, put in a chest drain, both sides, and resuscitated the patient. His hematocrit dropped from 41 down to 18 and gave some packed red cells and came up back to 33%. So what would you do? Some hospital would go and fix the fractured bone, but they chose wisely. They transferred the patient to King Chulalongkorn Memorial Hospital. So once the patient arrived at our hospital, the blood pressure now is 200/97 millimeters mercury. His pulse rate is coming down. His score is now with a tube. The patient has an intracerebral hemorrhage, and CT scan has a traumatic rupture of the aorta. So what's the sequence of treating this patient? Should the neurosurgeon evac the clot in his head first? Or should the surgeon fix the thoracic aorta first? Or should the orthopedics fix the broken bones first? According to the grading, grade 1 could be managed non-operatively. Grade 3 and grade 4 must be treated surgically, either by TEVAR or open surgery. For grade 2 is open for discussion. For open surgery for blunt thoracic aortic injury, the first case was done by Dr. DeBakey in 1950s. He did a primary repair, clamp, and sew. And then there's a graft. They used graft interposition. And then we know that if we just clamped and sew, the patient wouldn't do well. The heart strains and the distal body perfusion would have ischemia. So the point of consideration is some kind of bypass, active bypass or a passive bypass. Since 1993, the standard procedure is left heart bypass, like doing a descending thoracic aortic repair. The last open repair for blunt thoracic aortic injury in King Chulalongkorn Memorial is in 2010. After that, all the cases was done with TEVAR. So what are the current concerns of TEVAR for blunt thoracic aortic injuries? The sizing of the aorta, the high origin of the Adam cubics, the brain embolism, left subclavian artery coverage, and long-term follow-up. About the sizing, the patient's blood pressure swings from 90 millimeters mercury to 200 millimeters mercury. So the aortic size could vary from 18 millimeters up to 21 millimeters. Oops, sorry. Right? Okay. Are we back online? Okay. Nice one. Okay. Okay. Yes, sorry about that. And the tight angulation of the aortic arch in young patients. The next concern is the high origin of Adam cubics plexus. So the incidence of high Adam cubics plexus is about 15%, and as we know, the longer coverage of the thoracic area, the higher incidence of the cord ischemia. If we put in a TEVAR longer than 15 centimeters, you should consider some kind of spinal cord protection, such as CSF drainage, or keep a stable or up to high blood pressure, and some medications. About brain embolism, the incidence should be less than 3%. Like Dr. Kitishai said, if you encounter one case, it's too much. About left subclavian artery coverage, at King Chulalongkorn Memorial Hospital, we had a proposal that coverage of the left subclavian artery for blunt thoracic aortic injury repair is rarely indicated, which means the sealing zone doesn't have to be 20 millimeters like doing a standard TEVAR fixing an aneurysm. We did a sealing zone less than 5 millimeters and could cover the injury perfectly fine. So the study was retrospectively descriptive review from 2008 to 2020. We had 61 blunt thoracic aortic injuries, but we excluded 2 cases because we had to do a zone 0 and zone 1 repair. And as you can see in this diagram, we did a short landing zone, 50 cases, almost all of them we did a zone 3 TEVAR repair. So in conclusion, this retrospective review found that 59 patients with blunt thoracic aortic injury in the descending thoracic aorta over more than 10 years reflected our practice preference of avoiding left subclavian artery coverage. Blunt thoracic aortic injury repair with short landing zone less than 20 millimeters could be treated successfully without coverage of the left subclavian artery. Okay. And the last thing is the long-term follow-up. You have to do a CT scan every year. So back to our case, what we did. So we did a TEVAR in zone 3. If you look at the time, less than 30 minutes. Would we give heparin to this patient? The concern is the intracerebral hemorrhage, so we didn't give any headwind and did a standard TEVAR in zone 3. And as you can see, we still have a patent left subclavian artery. The vertebral artery on the left side is still open. Post-operative, 10 days after the whole body was fixed, the brain was evacuated, his legs and arms were fixed. We did a CT scan and found that the aorta is almost healed. And this is the patient before discharged. Thank you very much.
Thank you much, Dr. Kletaya, for a nice summary of the procedure of the endovascular repair in the blunt traumatic aortic injury. The next speaker will be Dr. Bunsap Sakbun. She's a cardiac surgeon from the northern part of Thailand, Lampang Hospital. Lampang is one of the big cardiac surgery center in Thailand, and with a good number and great experience. So Dr. Bunsap will share her interesting case, the TEVAR in the traumatic aortic injury. Dr. Bunsap, please.
Good morning, Chairman, panelists, and Medtronic Thailand. It's great opportunity. Thank you very much for great opportunity to be here to share our work about treatment traumatic aortic injury by TEVAR in Lampang Hospital. Lampang Hospital is a 700 provincial bed hospital in the north of Thailand. There are 4 surgeons, 2 operating rooms, and 8-bed ICU. About traumatic aortic injury case, we were consulted by ER doctor or trauma doctor. After CTA, some CTA whole aorta, some just CT chest, we can diagnose by CTA. No need IVUD or aortogram that we didn't have. Before the year 2013, maybe at least 1 case, my board performed open surgery and some refer. On the year 2015, we start non-elective TEVAR. TEVAR alone cases per year at show, and of that, 31 cases TEVAR that used to treat blunt traumatic aortic injury, about 16.4%. We don't have false positive CTA finding cases. Our patient characteristic, mean age about 40 years old, 100% abnormal chest X-ray, mediastinal site mean about 94 mm. Most cause of injury is motorcycle accident, and most were male. 100% associated injury, neuro, ortho, and general surgery have to join. Usually we perform TEVAR on the day 1, and some day injury depend on patient status and stent status, available site or not. We perform in our procedure of full time about 6 minutes, contrast about 30 mm, length of stay of patient about 17 days. Nearly most we use just only 1 stent, and 87% performed by cut down, just for cases percutaneous foci. And most we oversizing about 5%. And the case that we can perform CTA whole aorta, access site about 7 mm. Some case very small, just 5 mm. But lucky we didn't have access site injury due to stent, just one case, maybe due to kosher device. Nearly all Medtronic stent, just one case, not Medtronic, James stay with us. And we cover left subclavian artery 77%. Lucky, no limb ischemia, no paraplegia, no subclavian steal syndrome. 30-day mortality, 0%, no case, and late death with sepsis, 2 cases. And we got one interesting case, 27 years old male with motorcycle accident and multiple injury. Abnormal chest X-ray, mediastinum size about 100 mm. CT scan coronal like this, cross-sectional like this, very short distance between lesion and left common carotid artery. Sagittal view, very short, but at that time we decided to proximal land, put TIVA stent, proximal landing zone, distal to left subclavian artery, left common carotid artery. Landing zone very short, but at that time, no choice. Proximal diameter about 22 to 23 mm, and distal diameter 18 to 19 mm. We decided to go on our plan. In operating room, this is first angiogram. A bit exciting, very short, but continue. Confirm point of landing zone at distal to left common carotid artery. And finally, final run. Still some endoleak from left subclavian, but we stop operation and let other perform operation. And we follow up CTA 3 days after that. Very lucky, our endoleak was gone. And after that, follow up CTA again after 2 months. Still lucky. No endoleak. Patient's okay. In my opinion, I think because of TIVA, both patient and surgeon can achieve benefit. Patient no need to perform open surgery, big incision. For surgeon, more easy to perform TIVA. And another thing is teamwork is most important. Not only surgeon, scrub nurse, anesthesiologist team, or related department. I think one important is stent team also. I think they are not just only company that provide our product. I can feel that they try to do the best for successful treatment of patients. I think they are one of our team. And thank you very much, Dr. Charan, Dr. Natapon, my boss, who can stand by, back up every situation. And thank you very much, our pioneer who established Endovascular unit of Lampang Hospital, Dr. Angsu. Thank you very much.
Thank you very much. We have a very nice presentations about blunt thoracic aortic injury, and I'm sure that may create some questions, interest here. May I invite the speakers up on the stage, please? I'm not sure the panels have any questions or some add-on. Dr. Angsu, please.
Okay. Yes. Okay. Thank you very much. Very nice presentation in this morning session. I think everyone is enjoy a lot. First of all, I have a question for Dr. Wasin. Yes, I enjoy your lecture a lot and see a lot of improvement of endovascular surgery in Thailand. And as you show that the number of the endovascular surgery is increasing year by year. And do you think to control the quality and numbers of the surgery in EVA and TIVA, do you think we need the certificate for the endovascular surgery, each brand by brand, to control the quality of the endovascular surgery? Because when I stay in Japan, each brand of the stent graft, before you perform, you have to have the certificate for each brand and to complete the program treatment, something like that, to control the quality of the endovascular surgery.
I think that to some extent may help, but I don't think that would be all. For example, for percutaneous coronary intervention (PCI), we do have formal training program, interventional fellowship with certificate from the Royal College of Physicians Thailand. Still, our graduates who went out and practiced PCI, if the procedure can be easily abused, it will be abused. If the system of payment can be abused, it will be abused, both by physician, hospitals, hospital administrators. So I think that will have to have, besides official training certification, it's actually self-responsibilities for each of the doctors who would have to be, ethical, doing what they should do. The hospital will also be responsible for controlling their appropriateness of the treatment. And I think, because if that doesn't happen, the payer, in this case, our biggest payer is Sapasacha or National Health Insurance will step in. And when they step in, they only want to control the cost. I don't think our Ministry of Public Health ever look at the outcome of the treatment of the disease that we treat the patient. They just want to cut the cost, and their reputation came by when they are able to cut down the budget, not by improving healthcare. So we have to be careful for that. And I think what I just said is being recorded. Thank you. All right.
Thank you, Dr. Wasin. I really enjoy your talk, Dr. Wasin. Your slide is about the evolution of the TIVA. So you're with the TIVA from the beginning. And like the TAVI, if you imagine about the next 10 or 20 years, what it should be about the TIVA?
I think TIVA is here to stay, for sure, like PCI, like TAVI. I'm not doing that much now and have been follow the advancement of TIVA these days, and that's why I only can talk about the history, the past. But I think I would think it's like any other technology. The device itself will be improved, and the design will be improved to be able to get rid of the pitfall it has today, and also be able to treat more pathology in the future. And at the same time, I think the evidence on the outcome of the disease with and without treatment and with which treatment is also ongoing. And as we go along, we learn more and more. In the past, we didn't know, when or how to treat, PAU or intramural hematoma. And over time, so we have more data in terms of when we should do it and when we should not do it. So we have to kind of follow the two together, not just the technology and that just we can do it, so we do it. We have to also follow the evidence and to see if we should do it or not, or when we should not do it.
Can I ask Dr. Krittiya and Dr. Bunsap a little bit about the blunt thoracic aortic injury, because both were touching upon one of the critical issue, I think, is the ceiling zone, and that Dr. Krittiya mentioned that we may not need 15, 20 millimeters long. So rarely at the Chulalongkorn Hospital will cover left subclavian artery. But Dr. Bunsap in the practice showing that majority of the cases covered left subclavian artery. But the example that Dr. Bunsap showed seems like that very short neck also healed, right? I don't know what should be the practice that both of you will suggest. Is that 5 millimeters or less than 10, let's say, safe enough? And if it's safe enough, how to deploy it correctly? Because this very short ceiling zone, if we accept it, but we deploy, we missed it, then we may create some more problems.
Because just a bit experience, but my practice will feel comfortable if 1 centimeter landing zone, I think, is enough for my practice. And as my teacher said that injury mechanism like a circumferential, not have distance. So maybe at that point is safety, just 1 centimeter. And another thing is because we fix at distal part also. Distal part help about fix also. And for during deploy, very important. At that time, should wait until blood pressure 60 or 70, something like that, maybe more.
The mean arterial pressure, you mean?
Systolic blood pressure.
Systolic, okay.
I try to wait until they achieve that blood pressure.
So the reason all behind is going to be published soon from Chulalongkorn. Our thinking thought is that the aorta that is torn is used to be a healthy aorta, not a diseased aorta. So the ceiling zone doesn't have to be like 20 millimeters, fixed proximally and distally. Just cover up the lesion and the body will do the rest. So we try to put in just 1 stent like your team does and try to leave the left subclavian open. If there's still an endoleak, we could easily extend 1 more stent proximally. No major consequences. And so the next concern is doing the left subclavian to the carotid to left subclavian bypass. There's no need to do immediate reconstruction or bypass, unless if the patient has a lima to the LAD or has a functioning AVF or has a large vertebral artery, those kind of indication.
May question to the Dr. Bunsap and Dr. Krittiya about the tips and tricks in the blunt traumatic aortic injury treatment by the endovascular repair. Because your result is so good, so how can you tell us or share your experience? Maybe 2 major concerns in the treatment of the endovascular repair in traumatic aortic injury. Each of you, 2 major concerns in the treatment, please.
So one of my major concerns is in the very young patients, like in their teens, 15, 16 years old, and they have a traumatic rupture of the aorta. If we put in a stent, the first concern is the sizing of the stent, because 16 years old, the aorta would be pretty small, the angulation would be very tight. And if we did it successfully, we have to follow up the patient 50, 60 years from now. So that's one of the major concerns. Well, actually, that's my only concern for now.
For my practice, I think many points that we have to concern, but it look like it's really simple. When we have case, first of all, we think of TIVA, and we evaluate CT scan. If most is enough landing zone, but maybe just I said my data 70% cover left subclavian. I'm not scared too much, but have to concern if we want enough landing zone, maybe have to cover, and we have to think about vertebral artery site that Ajahn Krittiya mentioned, and have to observe. If we have to cover, we cover, and then observe, closely observe, but lucky no. And another thing is stent, because emergency situation, if we don't have on-shelf stent, we have to wait, we have to need help from company, try to find proper stent, because oversizing is important also. Try to not oversizing or oversizing less than 10%.
Thank you very much for your comment. So your concern is about the young patients, the proximal landing zone and availability of the stent, right? Thank you very much. So I think thank you very much for all speakers.
Ajahn Surin have
Okay,
some
mention, please.
Please give the microphone, please.
Have the short comments for the aortic injury. You don't care too much. Actually, is when you look at the CT scan, but in the operating room, it's different. It's longer landing zone. And the second thing, you cannot complete cover subclavian in young patient because it's steep and narrow of the angle. So in meaning, when you deploy, you think that it complete closure of the subclavian. No, it's back a little bit. The final thing is the benefit that you use if you use the bare stent in this situation, because it extends the catching of the wall. It's better than the non-bare stent in this situation, because you need only 1 centimeter in cover in the proximal and distal, so that you can prevent the rupture. After that, everything God help them to healing or everything. The second comment about the just like Dr. Angsu asked that, but it have to be just like the legislation or anything. Don't worry, because if the increased rate of the money just like it now, I think the National Health it look at you. Don't worry, winter is coming. At that time, you have to know that if you have to registration, they give you every type. Maybe the stent from China it come back at that time. But I don't know, because now you don't have anything to control. You can often use, maybe in the future, if you do just like that, maybe the doctor just finished 6-year student, maybe push the stent. No, you can do that. You cannot do just like that. But don't maybe it's coming, because 2 years ago we start with the National Health to check everything for operation in cardiothoracic surgery, but it stopped because of COVID. I don't know, maybe COVID it disappeared. Maybe they start to check again. Not too far.
Thank you very much. There are many things to continue to think and act upon. Thank you all the panels, Dr. Vasin, Dr. Unsap, Dr. Kritiya. Thank you very much. We will move on to the next session. We will continue with the thoracic pathology, move on to the more on the acute aortic syndrome. We have Dr. Vorapot Vithiyakrit Sirikun from Bhumipol Nadunyadej Hospital. I will come to talk about the aortic intramural hematoma with and without the penetrating aortic ulcer, when to treat and how to treat. And Dr. Vorapot, please.
Thank you to invite me to join this session, and I will share the experience about the intramural hematoma and penetrating aortic ulcer. As we know that acute aortic syndrome, we have three varieties. The first one is aortic dissection. Especially in type A aortic dissection, we all know that it's a surgical condition patient. But the two varieties of the acute aortic syndrome is intramural hematoma and penetrating aortic ulcer. That intramural hematoma first described by Krukenberg in 1970, and the pathology is we cannot see the entry part at the intima from CT scan. And the penetrating aortic ulcer is we see the ulcerated or disrupt of the internal elastic lamina, and we saw that it's localized lesion at the aortic. What should we do about the intramural hematoma and penetrating aortic ulcer? Because of the clinical presentation is similar, just like aortic dissection, and the morbidity and mortality are similar to aortic dissection. According to the IRAD study that we have, they recommend that type A intramural hematoma have, if you manage with medically, so you will have a significant mortality, 40%. Because of we don't know the real thing about the intramural hematoma and PAU, but it has a highly unpredictable behavior, and sometimes it's benign, but sometimes it looks malignant. And we should follow up to the progression of the disease. So the management of the type A, IMH, and PAU, we already know that surgical condition is the better outcome. But if some in patient with high risk for surgery, we can manage in medical management by in the condition that aortic diameter is less than 50 millimeter and intramural thickness is less than 11 millimeter. But also it has a significant worse prognosis. We must follow up. The problem that if IMH and PAU or with PAU in type B, what should we do and how to treat? I have a case to share experience, the case of IMH and PAU with PAU. Uh, 50 Thai, because he was a government officer, present with chest pain, severe chest pain, and must admit at CCU. At the first time we took the CTA that we have some penetrating aortic ulcer and intramural hematoma type B. In the first time, we decided to medical treatment for the patient, but you see, In the lower picture, 1 month later that we follow up, because patient have some clinical presentation, some chest pain. And you will see that the progression of the disease is more progression. It progressed to aortic, The lower one is 1 month later, it progressed to aortic dissection type B and have some pericardial, some pleural effusion. So we advise him to do the operation, to do the TIVA, and this is the 1 month after TIVA. The dissection part was disappear and have some pleural effusion fluid and action around the pleural. And the lower picture is 1 year after the operation. The outcome is very good for TIVA. So, for recommendation, treatment for MH type B, if the patient is symptomatic, we can wait and see and good follow-up for the patient. But if the patient have symptomatic, the persistent pain or the progression of the CT finding is progressed to ulcer liposuction, and we have some impending rupture or progression to the aortic aneurysm, we should treatment for the patient. And the treatment choice, we know that for TIVA is the more have good mortality, good long-term, low morbidity and low mortality. If the anatomical is applicable, it's easy for the patient, we can choose TIVA first. But the natural history of PAU is still unknown. So maybe some authors said that it looked malignant, so they advise to treat everyone. But for the recommendation, we just looking for the clinical of the patient and anatomical suitable for the patient and the consent with the patient. If do TIVA, what is the complication? And if wait and see what is the complication, you must explain the patient. But be careful, if you perform the TIVA, you know that have some complication of the TIVA, just like distal retrograde aortic dissection that may occur after TIVA, and sign is the major complication of the TIVA. We should learn and take care of the patient. In summarize, this picture shows that acute type B, IMH or PAU, if the patient have sign of the or complication of the disease, you must, first choice is TIVA suitable, you must perform TIVA. If the TIVA is not suitable, open surgery is the recommendation. But for the patient, no clinical symptom and no complication, we choose medical treatment and must be close follow-up the disease. If the progression of the disease have a complication, just like retro intramural hematoma, or the growth of the aortic diameter is greater than 5 millimeter per 6 months or 1 centimeter for 1 month, or the perform, it continue to be aneurysm, that you must be treated with the treatment, and the choice is the same too. is it anatomical suitable for TIVA, you must use TIVA. And if the anatomical is not suitable for TIVA, so open surgery must be performed. In summary, we know that MH and PNU are one variation of the aortic dissection of the acute aortic syndrome, and there have three difference regarding that pathophysiology is different, imaging and the TIVA planning for the patient. But until now, no comparative study published compared with MS and PAU, and the management is based on the legacy evidence. Thank you.
Thank you very much, Dr. Warapot, for the summary of the IMH and PAU. So the next topic, we will keep the question at the end of the session. So the next topic will be the endovascular tips and technique for achieving optimal outcome in acute complicated aortic dissection, presented by Dr. Nopon Taksaudom. He's a TAVI and TIVA and congenital cardiac surgeon. Dr. Nopon from Chiang Mai University, please.
Thank you, Chairman and Co-Chairman. Today I would like to present endovascular tips and techniques for achieving optimal outcome in the acute complicated type B aortic dissection. The acute complicated type B aortic dissection has been treated with the peripheral bypass and open aortic fenestration. However, the mortality is quite high, nearly 30%. And also the rupture type B aortic dissection. And all day we have only one choice, it is the open descending aortic replacement, and the mortality is near more than 60%. And then in the TAVI era, we can reduce the mortality rate to less than 10%. Currently, from the new guidelines, both STS and the ESC, there is not just only complicated or non-complicated, but right now they have a high risk. In this table, I try to summarize all of the high risk and the complicated from both guidelines in one table. You can see that some high risk in the SCS is defined as complicated in ESC. But the indication, both high risk and complicated, we should perform the TIVA. So it is not need to be clearly defined as high risk and complicated, but the problem is about the timing. So the SCS used just only rupture and malperfusions as a complicated one. This is a SCS guideline. In the complicated type B aortic dissection, they recommended to perform the TIVA in whatever the phase it is. And the open surgery is recommended just only if the patient is unsuitable for the anatomy for TIVA. And fenestration is optional. And from the guideline, they talk about the timing of intervention. They suggest to delaying the treatment beyond 24 hours up to 90 days. Because if you look at the paper from MEIRE, they performed the TIVA in hyperacute patient, and they found that it is significantly higher in mortality, hospital mortality, than in the acute or subacute, and also higher in 30-day mortality. However, Pathologies also report about the change in aortic morphology can cause the poor prognosis in the subacute type B aortic dissection. Therefore, the optimal timing of the TIVA should be individualized. And the fundamental of the treatment by TIVA in the type B aortic dissections have only two important points. One is occlude the primary entry tear. Two is restore normal blood flow into the true lumen and its major branch. As everyone knows that there is a number of risks of the spinal cord ischemia in the TIVA. If you put the long stent or you cover the lower thoracic aorta, or if the patient has a aortic surgery or impaired subclavian arterial supply, the risk of the spinal cord injury will increase. And the ESC proposed the four-stage concept that is more easier to understand. There's four major inflow: the subclavian artery or the vertebral artery, thoracic segmental artery, lumbar segmental artery, and the hypogastric artery. If only one major is lost, it's less likely to cause the spinal cord ischemia, but if two majors are involved, the risk will increase. However, the prior infrarenal aortic replacement or the EVAR is not a risk from the ESC guideline. The SCS guideline suggests to put the preoperative CSF burn rate in the patient at increased risk of the spinal cord ischemia and the time permit. And also if the patient had a paraparesis or the paraplegia after performing a TIVA. The wire location is the most critical step of the procedure in the acute type B aortic dissection. You must always keep your wire in the true lumen from the femoral artery to the endpoint in the ascending aorta. The transesophageal echo can help you just only at the endpoint, but not the origin of it. The eye width is a very useful tool to locate the wire. It's not just only to use to confirm the location of the wire, but it also can localize the tear and finalization throughout the ascending aortic involvement, confirm healthy proximal landing zone, confirm the aortic measurements of that obtained by the CT scan, and also the after the procedure. You can use it to rule out the retrograde aortic dissection, demonstrate the dynamic change in the true lumen and the false lumen, assess the branch vessel compromise, and determine the static obstruction. After you confirm the wire location, now you have to concern about the landing zone. The proximal is not equal to the distal in the type B aortic dissection. The proximal is relatively normal aorta and is quite easy to measure. The oversizing should not more than 10% to avoid the retrograde type A aortic dissection. On the other hand, the distal is a dissected aorta mostly, and it is a high degree of bias in measurement. There is no consensus on this topic yet, and the oversize we can around up to 20%, but not more than this to avoid the distal size. We accept the proximal landing zone at least 2 centimeters proximal to the primary entry tear, and the most proximal part should land on the relatively normal undissected aorta. And as I said, the oversizing should not more than 10% to avoid the retrograde type aortic dissection. But what is more important, the length from the primary tear or the relatively normal aorta? If you look in this paper tries to focus about the impact of the intramural hematoma at the seal zone in the thoracic endovascular aortic repair for the type B aortic dissection. If the stent is land on the intramural hematoma and the seal zone, the patient will have a retrograde type aortic dissections more than the patient that land in the normal aorta. Therefore, the relative normal aorta is still important for the proximal landing zone, not just only the length from the primary intimal tear. And then this paper focused on the zone, the most proximal zone that the TIVA that put in the type B aortic dissections. And then they divide into two groups. One is the landing on the zone 2, and the other is landing on the zone 3. You can see that if you land on zone 2, the patient will have the re-intervention lower and the freedom from the aortic related event is higher. Somehow from this paper, maybe you can conclude that if you land the most proximal landing zone in the relatively normal aorta, you can achieve the better result in the type B aortic dissection. The SCS guideline report about the list of the retrograde type A aortic dissection is included the stent graft oversize, the use of the proximal base stent, the aortic arch dilation, the proximal tear size between the aortic arch, and the notable the big leaking. But they report that the stent graft landing zone proximal to the left subclavian artery is the risk of the type A aortic dissection. So I cannot conclude on this topic, which is the better area for the put the stent in. And if you put a stent on the zone 2, the left subclavian revascularization is another concern. There are many indications for the left subclavian artery revascularization. In the guidelines suggest to revascularize subclavian artery in order to prevent the spinal cord ischemia. And now we will talk about the distal landing zone. The acute and the subacute is not equal to the chronic. So there is no standard measurement of how can we measure the actual size of the distal landing zone. Some institutes measured entire of the aortic diameter because of very variable symptom that the TIVA can expand the true lumen to overcome all of the aortic size. And also allowable for the distal oversizes 10 to 20%. However, in case of with a marked discrepancy, the telescopic still suggests. But how can we measure that? This is an interesting paper from Osaka University that talking about this topic. Everyone knows that after the dissection, the size of the aorta is not normal. So they found the patients that had a preoperative CT that performed within 3 years before the dissection, and they measured after the dissection and found the best aortic measuring technique to predict the pre-dissecting aorta. And finally, they found two techniques. The first technique that used the post-dissected whole circumference plus the post-dissected two lumen circumference length, and then divide by 2. The other, it used the maximal and the minimal overall aortic size, and then divide by 2. And it is a formula that I just already mentioned. And they found that using the circumference of the overall aorta plus the true lumen circumference and then divide by 2 has the best correlation with the pre-dissecting aortic diameter. And after using the complex mathematical method to modify the equation, even with using the maximal aortic diameter plus the minimal aortic diameter and divide by 2, if you multiply with 2.7, it also has a better relation with the pre-dissecting aorta. And the formula that using the circumference here also has the best correlation in every subgroup of the aortic morphology. Look at this example case. The pre-aortic diameter is 66 millimeters. If you use the formula with the circumference, you will calculate it is 65.7. But if you use a diameter that you have to multiply by 2.7, you can measure is 67.6. That is quite a good correlation with the pre-dissecting aortic diameter. There is some special concerns about the telescopic technique. Sometimes you have to place the distal stent first because the distal aorta is smaller. But if you cover the large re-entry, it can increase the force lumen pressure, and sometimes it induces the retrograde type aortic dissection. In order to prevent this complication, some institutes propose about the 3 pieces to repair. Put the proximal stent first, and then follow with the smallest distal piece and connect each other with the middle piece. And the next topic is about the length of coverage. The essence of the aortic coverage is to remain a controversial topic. We know that we have to cover the primary intimal tear and all the large secondary tear in the thoracic aorta. But how long of the TEVA that we have to put in? Some institutes propose the aggressive approach. They cover entire of the thoracic aorta from the subclavian artery to the celiac artery in order to achieve the better aortic remodeling. And everyone knows that if there is a rupture, we have to cover entire of the thoracic aorta for sure. But some institutes propose about the step-by-step approach. They aim to fully open the two lumen. They put the stent at least 2/3 of the thoracic aorta, and then use the angiogram or the IVUS to confirm the good visual blood flow and no sign of compromise. If there is a compromise of the blood flow or the compromise of the two lumen, they will put the stent down to the celiac artery. And if there's still abdominal malperfusion or the collapse of the two lumen in the abdomen, the petticoat technique using the bare nitinol stent to expand the two lumen is the other option. The balloon angioplasty must be avoided to prevent the retrograde type A aortic dissection. And if there is a markedly complex of the lumen, you have to trust on the radial force of the nitinol stent graft that can gradually expand the two lumen over time. And the topic about the malperfusion, just wait for him. He will talk about the malperfusion and rupture in the next topic. The special issue is about the connective tissue disorder. In the guidelines still suggest to perform the open surgical repair that is more durable. However, if there is a complicated type aortic dissection with an anatomically favorable for TEVA, you can use the TEVA as a bridging in the connective tissue disease. But you have to plan the delay open reconstruction after. If you use TIVA in the acute type A aortic dissection with the connective tissue disease, you have to keep in mind that the risk of the retrograde type A aortic dissection and the distal size is increased. From the data from Dong and colleagues, he found that the retrograde type A aortic dissection can develop 3 out of 4 MAM patients, and the incidence of the size was 10 times higher in the MAM patient. And this is the last slide that I think it is the take-home message for everyone to preventing the complication to perform the TIVA in the acute complicated type B aortic dissection. Careful and minimizing the wire manipulation and also the catheter. And you have to control the blood pressure to less than 100 and the heart rate should less than 90 beats per minute before you deploy the stent. And use the CSF drainage if you plan to cover the aorta more than 2/3 of the designated thoracic aorta, and avoid the balloon of the stent graft. And that's all of my presentation. Thank you for your attention.
Thank you very much. I think this is one of the still need to find the best solution for the patient. So glad that today we have a chance, and we will continue on this topic about this complicated type B aortic dissection, a ruptured or malperfusion, how to survive in this situation. Dr. Pasakon Noiniyom is a cardiothoracic surgeon from Yala Hospital. Will share with us this in this topic. Dr. Pasakon, please.
Thank you, Mr. Chairman. Good morning, everybody. Today we will talk about how to survive in complicated type B dissection. Thank you, Dr. Nopon. He already gave the detail of dissection. So I want to share the case. Today I will talk about the type B dissection and the complicated acute type B dissection. Dr. Nopon already gave all the details, so I will talk in short about all this. Finally, I will talk about the interesting case, my experience in acute type B dissection with the ruptured aorta. Acute type B dissection, the disease that's caused by intimal tear resulting in the separation of the aortic wall. Account for 25 to 40% of the all aortic dissection. We can categorize it into uncomplicated and complicated type B dissection. What is the complicated type B dissection? Is the dissection type B that have rupture, impending rupture or malperfusion. Sometimes we including the refractory pain and uncontrolled hypertension into this group because this also need the intervention for treating this condition. It's account for about 15 to 20% of the cases. I will separate into the 2 areas of the treatment. First, before the stent era, we have the choice of just the open surgery. If it rupture, we put a graft, open graft replacement, and if it has a malperfusion, we do open fenestration to treat the malperfusion. It have a quite high mortality in the part. Some papers say that maybe the mortality in type B may close to the 30% in the parts. The idea to do the fenestration is to make a hole between the true and the false lumen for neutralizing the pressure between the two of the lumen, so the blood can go better in the true lumen. In the stent era, most of the complication of the type B dissection we can treat with just only put the stent covering the primary tear. It can help in both rupture and malperfusion. Anyway, in some cases, after we put the stent, it still have the occlusion of the branch. Some center can put the stent into the branch to treat the malperfusion. Or in some center also can do the fenestration by the balloon dilatation. Anyway, you must keep in mind that the open surgery is still the good choice if you have no choice. If you put a stent and the malperfusion still have occurred, you can do the open fenestration with the TEVAR. The stent looks so good in this era, but you must know that if you put a stent in the long term, you may encounter with the terrible aortic disease. Resulting from the stent, you must choose between the natural progression of the aortic disease, or maybe you must encounter with terrible of the complication of stent. So you must have a good plan for put the stent into the patients. This is my case I want to share with all of you. The patient was a 57-year-old male, present with the back and abdominal pain and hypotension. The CT scan of this patient have the type B dissection with the left pleural effusion. It's a highly feature for type B dissection. In the abdomen, you may see the retroperitoneal hematoma and a rupture triple A. At that point, what in our mind, for the plan for this patient, what the choice you have to treat this patient. For me, I have the three choices to treat this patient. First, I think about the TEVAR plus EVAR. Second, I think TEVAR plus the open surgery, because I'm not sure the EVAR can press on the dissecting part of the aorta. It's quite dangerous. In the final choice, I may choose the open thoracoabdominal repairment. What's the point of concern in each choice? If I choose the TEVAR plus the EVAR in this case, the point of concern is about the next of the EVAR. I think it had just only 8 millimeter that the aorta was good enough to put the stent. Beyond that, it was a dissection. And other than that, you may see the patient also have the malperfusion on the right kidney. So if you put the EVAR, you may lose this kidney. Second choice, TEVAR plus the open repair. What is concerned in this patient? I must put the clamps on the aorta that has a dissection. So it may be rupture, or it may, in the long term, they will progress to the aortic disease at the clamp site. And with this large hematoma, sometimes the patient will develop the compartment syndrome, abdominal compartment syndrome that may cause renal failure after operation. The last choice, if I do the open thoracoabdominal repair, the problem is quite take time to recruit the team in the night in the emergency situation. It's very difficult to recruit the team for thoracoabdominal surgery. So it has a high mortality and morbidity in low experience centers, especially in the emergency situation. It needs a cardiopulmonary bypass. So I looked for the case report, what the other doctor do if they have this situation. So I found this report. I found that most of the patients who have this condition need the re-intervention, whatever you do in the first in the primary operation. One patient underwent the TEVAR but the open abdominal had a re-intervention due to the progressive aortic aneurysm because of at the aortic cross campsite. So they need the re-intervention just only in 4 months. The other patient have underwent TEVAR plus EVAR. He had to re-intervention at the 9th year. This sounds good. And the last choice is the open abdominal. It's quite good in long term, but the problem is a very, very high mortality. For me, this is planning. TEVAR is not difficult. It's just a simple, but I don't have the time to do bypass to the left subclavian, but anyway, I can just partial cover it. You may see because of patient have very narrow of the aortic angle, so you don't take any benefit to go beyond the left subclavian because it's very narrow. And for the EVA, I plan just place the EVA just below the renal artery and not oversight at the part of dissection. And my idea, I think I put the TIVA first, and it may decrease the pressure on the foramen, and the landing zone will be better. This was the final result. I do the TIVA plus EVA. The mobility time is just about 1.5 hours. I don't need a special team for this case. These are CT scan after 2 months after the operation. After the operation, the patient have left pleural effusion, so I put the ICD on this patient. This is a CT scan. The foramen was completely obliterated. They have no fat anymore. In abdomen, have no leaks. We can save the left kidney. The right kidney have some sign of slow flow to the right kidney. The stent look good in this case. So in this case, we can remove the endotracheal tube just after the operation. In the CT scan in his last visit last year, it's almost 2 years after the operation. Conclusion, the stent play a major role in the treatment of the aortic dissection nowadays in both type A and type B dissection. But anyway, you must be aware of its complication, especially if you decide to put the stent in the low risk patient, in the patient with uncomplicated type B. So you must think again and choose the right side, choose the right handling for the patient, because in long term you may encounter with the terrible aortic disease. Thank you.
Thank you very much. Now we'll have some time for Q&A. Please, all the speakers up on the stage. Our panels have any comments or questions for our speaker? We have another speaker. Nobody is still on online, right? So all speakers are here.
Okay.
Yeah.
Okay. Dr. Brinton, you will ask first.
Okay, I have a question for the all speaker. You use in the acute dissection type B, not the MH. You use the bare stent or you go on the covered stent?
I use the standard stent. I never use the bare stent.
You use the stent that have the bare stent in the proximal or not?
No. Never.
Sorry, a little bit louder, please. We can't hear very clear. The question is about the bare stent, right?
Yes,
the
yes.
bare stent in the acute type B.
Yes,
Yes.
acute type B, not the MS type B.
And the question and the answer, I'm not sure.
I never use the stent with the bare stent for type B dissection.
Okay.
I use only cover stent.
And Dr. Nopon?
For me, about the bare stent at the proximal end, right?
Yes, yes.
I think right now we have a limited choice for the stent that doesn't have a bare stent at the proximal end. So, and in the most recent year, I used both, and I don't feel that there is anything that make more concern about the retrograde type A aortic dissection, because right now I think we have more knowledge about the bare stent that we don't need more number of the bare stent, and the length of the bare stent should not long. So now most of the bare stent that used in the market is just used for the radio, not for the radio fault, but for the alignment. So right now, I think it's not so significant about the bare stent at the proximal end in the aortic dissection.
So thank you so much for every speaker lectures. I enjoy a lot. So I will ask all of the speakers about the type B IMH in acute. So if the intramural hematoma was extended up to the left subclavian artery, and you plan to do the TVAD in zone 2, but the proximal landing zone that's free from the hematoma is only 1 centimeter. So do you still land in zone 2 with 1 centimeter landing zone, or you will move up to the further zone 1 or zone 0 or something? Maybe Dr. Vorapot first.
For my experience, depend on the clinical of the patient and the anatomical suitable for TIVA. Anatomical suitable for me is in IFU. If the anatomical just 1 centimeter at zone 2, that maybe, and not in a healthy aorta, we must look at the patient status. If the status is not too old, the standard is to maybe open surgery. But if the patient have high risk surgery, it depends on the clinical. If the clinical symptom is symptomatic, we just wait and see and follow up. And if the patient have symptom, we must discuss to the patient. For me, I'm not the expert on open surgery, and the outcome of the open surgery is not good enough. If the patient would like to open surgery, I will discuss to refer to the aortic center that have a good experience.
For me, in type B dissection or PAU, I don't believe that we always need a 2 centimeter landing zone. I just want the normal, good enough aorta to put the stent and the proximal stent, maybe just 1 centimeter, because I don't believe that it has endoleaks. We think that in type B dissection, I believe in alignment better. I don't go far beyond the angle of the aorta. If the stent, if it's here the bird beak, I think it may cause the artist. It will get dissection type A. So I don't go beyond the zone 2. If I must do more than this, I may do percentile better.
How about you, Dr. Nopon? Did you hear?
I think I have the same idea with both Dr. Pasakon. From the recommendation, they measured 2 centimeter that measure from the primary intimal tear. But however, the most proximal landing zone should be the normal aorta. So I still accept that if there is just only 1 centimeter, but this stand from the primary tear is more than 2 centimeter. I accept that.
The question is for IMH, we don't see the tear. We see only lumen and the hematoma. Most of the time, hematoma will be, let's say, distal to the left subclavian. In some cases, we can see a little bit of extension beyond, proximal to the left subclavian artery. Now, we don't see the tear. We have no idea where to start, what to do, what the speakers recommend us to land our proximal stent. Should we treat it like a type B you mentioned, or should we cover the left subclavian, or what? Any suggestion for us?
I still suggest to cover. I suggest to cover the left subclavian artery, but not attend that to the common carotid artery. In my recommendation.
Do the same. Yeah. Do the same, Dr. Pasikon, Dr.
Yeah.
Rapot? Yeah. Can we just don't cover left subclavian artery? We just land distal. Suppose that it like a type B. I don't know. Just curious. If we have an image, let's say more than 10 millimeters thickness, mostly distal to the left subclavian artery, we might see some little hematoma, not thick, but just little extension. If we land our stent distal to the left subclavian, is that acceptable, or we should go beyond left subclavian artery?
Normally, if in elective case, I try to translocate left subclavian in every case, because I think in the future, if the patient have the complication like retrograde dissection or anything, doesn't need the second operation, it's more easier to do total art with the patient who already have the translocate left subclavian. So if in elective case, I normally try to translocate and cover the left subclavian.
For me, I try to cover left subclavian for a good landing zone and carotid subclavian bypass.
Yes, as I mentioned in the paper, that in my slides is that if we go more proximal, the recurrent, the re-intervention rate is lower, and if we land in the area that still have the intramural hematoma, the incidence of the retrograde type A aortic dissection is increased. So I still suggest to go a little bit further for more safer, I think.
Hello.
Okay. That would be a good idea, like in a traumatic injury. We would go maybe like partially cover the left subclavian artery if we don't want to do the bypass, right? May I ask one question? In case of the patient with no clinical malperfusion, but the angiographic or radiographic is severe malperfusion, the true lumen is quite small, but the patient has no symptom. What is your suggestion to treat this kind of patient, the type B dissection with radiographic malperfusion?
I quite have the tendency to use the stent. Normally, I plan to do a stent in nearly every case of type B dissection, but but I never go beyond the type 2, because if someone needs to go beyond the type 2, I will follow up, because I think it's too much for preventing the long-term complications. But in the other patient, if we can put a stent just in the zone 2, I have the tendency to put a stent in nearly all the patients.
Sorry, maybe I'm not clear in my question. My question is the patient with radiographic malperfusion, acute type B with radiographic malperfusion.
Maybe
so
like kidney, like one kidney disappear, right, or something.
Or visceral, like a dissect to the celiac and SMA, but no clinical. The treatment is, your comment is endovascular repair.
Yeah, normally I have the tendency to put a stent, the standard TIVA in nearly every case. If I think in the long term it have a low risk of complication. So if even a small radiographics, I also start with the TIVA first. Yeah.
And the timing for the treatment is acute period or wait for the subacute period?
In my center, we have the problem that if we delay to the subacute period, we lost all the patients, because the patient never come back to follow up.
I see.
So,
Okay.
so I will do it in the same admission, maybe 2-3 days or maybe 1 week.
Okay, Dr. Warapot and Dr. Nopadon.
If the radiographic finding have malperfusion I think it's a little bit patient, because if the patient have radiographic malperfusion, mostly they will have clinical malperfusion too. So if the radiographic malperfusion, we must talk with the patient for the clinical that maybe patient cannot explain us. And if the treatment of choice is anatomical suitable for TIVA, if the anatomical suitable, we may suggest for the endovascular treatment. And if the anatomical not suitable, we must discuss with the patient. I have one patient that anatomical not suitable, we must landing on zone 2. And we discuss with the patient, you must have a carotid subclavian bypass, and the complication of stroke may be occur. They decide, okay, I just wait and see. And I follow up him for 4 years now. He's still healthy.
Dr. Nopon, any comment?
For me, if there is the radiographic malperfusion, I think the guideline classify as a high risk. So in my idea, I will perform it in subacute phase. But in my institute, we admit the patient until 2 weeks, and then we follow up the CT scan. And after the CT scan at 2 weeks, we will perform the stent after that, I think. But I think if the ideal, we put IWAS in, and we can see that there is any significant malperfusion or not, and we can decide what we will do if we have the IWAS. But IWAS in my institute also don't have a probe that can perform in the aorta, so I still never use the IWAS in the aortic dissection yet.
Okay, thank you. That seemed to be our speakers more a little bit aggressive. Yes, Dr. Solin, please.
I think
Any comment?
you may misunderstand with Dr. The chairman said that it meaning you see the collapse of the true lumen, but still have the perfusion to the visceral. That meaning is a high-risk patient. Don't worry about that. If you can pass catheter in the true lumen, you can put the stent. Because we have 1 or 2 or 3 cases, and my young staff that consult to me that how they do that, because you cannot see the true lumen in the abdomen. But we really large NT tear after repair, the type A dissection is around 1 week. So I said that you put the stent. And after that, everything is open. That the meaning is if you find it, if the patient don't have the clinical is meaning don't have the lysing of the creatinine or the sign of bowel ischemia or anything, that the meaning you can wait 1 week or 2 weeks. But it's very important, you have to keep the patient inside the hospital and you repeat the CT scan every week. Don't leave the patient and come back in 1 month. No, you cannot do that. If you find this malignant or unstable CT scan, you have to keep the patient in the hospital. That's very important.
I tend to agree. I think if we see ischemic, it's ischemic. Radiographic, clinically is ischemic. Means that if we don't do anything, we will lose that part. Come back another day, even 6 hours, 10 hours, it's gone. So no point to treat it subacute, in my opinion. If we don't treat it right now, it means that we don't treat them. I mean, ischemic infarction, let's say kidney infarction or something. I may be wrong though. I still believe that if we see some ischemic, even though no symptom, I think we need to treat them. It depends now, can we treat them is another issue, but we have to treat them right now. Because if we wait for symptom occur, we may one step behind. And then the best option to fix the problem is gone. But if we want to fix it, can we do it? That's another story. Can we do it safely? How we will do it? But I think we should go, like computer 010101, do or do not do, do or not do. In this situation, I think we have to be clear. We will attack it, and then we will move on. I'm not sure is that different. I mean, it's dangerous or not, but I think that's what my opinion looking at Dr. Worobong's question, and I think that's we rarely see it, but when we see it now, we kind of confused what to do.
No. Ischemic is meaning malperfusion. If you see the ischemic in the CT scan, it not benign. It's different. If you have the perfusion, it's no sign of ischemia in the organ or anything. That's meaning it's unstable, but not malperfusion. If you see the ischemia, partial ischemia of the kidney, that meaning the urgent emergency to do anything, everything for correct that. You cannot waiting for, because it meaning is malperfusion. It's different.
The question that I propose is that because we lost the patient with asymptomatic, with severe angiographic malperfusion, he had a high blood pressure, and then we tried to keep the blood pressure down to control the blood pressure. And then overnight, the symptom develop and it goes so fast. The totally bowel is gone, and we lost the patient. So I think that in this situation is quite, we have to keep an eye on and continuous monitoring in this patient. If it's no symptom, and if we don't think we need to do it right away, we have to close follow-up every hour. And then, because if we keep the blood pressure down, the malperfusion can be occur.
Yes. Do you mean that just only compressed lumen in the descending aorta or dissection
at the visceral area?
You mean dissection into the SM?
Right. The true lumen at the descending aorta is small too, and it's dissect the select and SMA. But he has no symptom. The no lactate increasing, and kidney is good function by the lab. But just overnight, everything is gone so fast, and then we lost the patient. So then I think that in this situation, maybe keep an eye on and continuous monitoring, and maybe attack to the intervention if something happens. Yeah.
Seems like we have a very interesting issue to discuss more, I guess. But unfortunately, we have to stop for this session. Thank you very much for our speakers, all three speakers, Dr. Waraput, Dr. Nopon, Dr. Pasakon. Thank you very much.
Hello, welcome back to the second session this morning, and we'll still on the treatment of thoracic aortic pathologies, part 2. And in this session, we have 4 speakers and also the foreign speakers. So our panelists still here, Dr. Ansu and Dr. Parinya. So Professor Huivu is still with us. So I will start with the topic of the hybrid repair of thoracoabdominal aortic aneurysm after chronic type B aortic dissection, which is a very interesting topic because it's a big challenging. So we will present by Professor Ai Hui Wu. He's chief of the cardiovascular surgery department, National Taiwan University Hospital. Professor Wu, please.
Thank you for the organizing committee to invite me to join the Medtronic Aortic Master 2022 in Bangkok. Today, my topic is to talk about the hybrid repair of the thoracoabdominal aortic aneurysm after chronic type B aortic dissection. I'm Dr. Yi Hui Wu from National Taiwan University Hospital. Today, we are going to talk about the Crawford thoracoabdominal aneurysm. You can divide it the type 1, 2, 3, 4, and additionally type 5. For the thoracoabdominal aortic aneurysm, the traditional open repair, I think, is still the gold standard up to date. However, there have been publication of the hybrid repair approach, and also the currently with the new devices and the image fusion technology, we can do the total endovascular repair of this kind of lesion. The open thoracoabdominal aortic repair, I think even now up to date, is still the gold standard surgical procedure. However, you need some adjunctive therapeutic option, including the left heart bypass, hypothermic arrest, spinal cord protection, and a really high standard in perioperative and the intensive care. I think the major morbidity and mortality still remain a concern, and in the conventional AAA open repair, especially in the high-risk patient group. This is one of our cases at 84 years old female with the chronic renal disease and presenting the mycotic thoracoabdominal aneurysm, and really not an anatomical case for the total endovascular repair. This is the post-operative CT scan follow-up. I think this is the graft to the SMA and the ciliary artery, and then we put in the stent in the renal and the SMA stent for the anastomosis. And with the open surgical procedure, I think the Dr. Kosali, they report that they're really excellent result with 30-day survival at 95%, and paraplegia rate at 3.8%, and renal failure at 5.6%. I think that data cannot really reflect to the real world data for the open thoracoabdominal aortic aneurysm repair, because in this data you can see that the average in-hospital mortality was about 20%, and even higher, much higher in the lower volume hospital center. We started to do a little bit of a hybrid approach from 2007 to 2011, and we also publish our data is that we do the visual debridging and put in the stent graft as the hybrid procedure. This is how we did the cases, debridging, and then put in the stent graft. This is the table showing that all the hybrid repair data that from 2004 to 2012. And I think the average, the mortality is still about 10%, and the paraplegia rate is about 10%, and the follow-up months is about 20 months, and the patency of the visual graft range from 89% to 100%. So starting from the 2013, we started to do all the total endovascular repair with penetration of branch graft. So actually, we know that the endovascular repair has been applied to the treatment of the abdominal and the thoracic aneurysm to decrease the risk and the benefit of pre-procedural complication. And the possible benefit really include avoid a major thoracoabdominal incision, avoid aortic cross-clamp, and decrease the blood loss, decrease the perioperative pain, decrease the respiratory dependency, and decrease the incidence of visceral, renal, and the spinal cord ischemia. So for the complex thoracoabdominal aortic aneurysm repair, what is the treatment option? I think in our center, we have the option for the chimney procedure with the octopus, or the flood procedure, that's the forced human intervention to promote the remodeling and the thrombosis, or the penetration graft that we can choose, or the branch graft that we can choose. In our center, we did a couple cases of the octopus procedure from 2015 to 2017. This was a case demonstration with 61 years old female with underlying hypertension and the old cerebral event. She had a renal bypass 15 years ago with occlusion and renal atrophy. And she was incidentally found to have intrusion size of the pararenal aortic aneurysm. And this is the centerline CT scan. You can see that just very juxtarenal aortic aneurysm cases. This is the planning that we use the AAA devices and putting the 3 visual artery branch in the contralateral leg and extension of the ipsilateral leg to the distal abdominal aorta, and with the excess from the bilateral axillary artery. This is how we expose the bilateral axillary artery. And this is the intraoperative CT end scene. So you can see that we open the AAA stent graft, and we cannulate the gate, and we cannulate the renal artery, and then we cannulate the SMA, and then we cannulate the ciliary trunk. And I think all of this has to be done in one setting, because these are all the chimney procedures. So you have to open that, open them together in one setting. And then this is the follow-up, the complete angiogram. This is the CT scan follow-up and the 3D reconstruction. The other technique we use to treat the TAA aneurysm repair is the false tumor intervention to promote remodeling and thrombosis. You can see that in these cases, it's a dissection aneurysm, and we use the false tumor occlusion with the fenestration Taylor technique. So the treatment strategy was primary coverage with TIVA, and the renal artery reentry cover with the cover stent. And you can see the renal artery penetration cover with the balloon expandable cover stent. And then the bilateral common iliac artery kissing stent with the cover stent, and the false tumor exclusion with the plug. And this is the final angiogram. And this is the post-operative CT scan follow-up. You can see that nicely exclusion of the false tumor sac. And then we shift the gear to treat the pararenal AAA with the fenestration, custom-made fenestration stent graft. This is one of our cases with previous failed AAA repair with the distal stent graft migration. So this is the CT scan. You can see that it's pretty distal migration of the previous AAA stent graft. This is the intraoperative scene. You can see that we always use the onlay fusion, CT fusion for the renal artery super selective cannulation. So this is the case. We also put in the SMA stent and the bilateral renal artery stent graft with the IFU procedure protocol. This is the final angiogram. This is the post-op CT scan follow-up. You can see that nicely exclusion of the aneurysm sac. And then the other technique that we use for the thoracoabdominal aneurysm is the T-branch graft. This is a case with 70 years old male with underlying with myasthenia gravis and chronic kidney disease and hyperuricemia. This is the CT scan. You can see that pretty much dilatation of the thoracoabdominal aneurysm below the T6 level. So basically, this is a Crawford type 3 thoracoabdominal aortic aneurysm cases. This is the preoperative planning for this patient. We plan to cover pretty much from the left subclavian to the distal abdominal aorta because of the restriction of the size diameter of the T-branch is only 34. So for this patient, 34 cannot fit in his T6 level thoracic aortic aorta. So we have to extend proximally to the left subclavian artery and use the taper stent graft to fit in that this T-branch graft. So this is the intraoperative scene. We can see that we deploy the thoracic stent graft first, and then put in the ready to put in the T-branch graft. And then we put in the T-branch graft, and with the branch orientation, we also use the onlay CT fusion to orientate all the visual artery location. And then we open the T-branch graft at one stage, and then we take out the big sheaths from the right groin and start to perfuse the pelvic circulation. And then we can super selective cannulate the T-branch branch graft from the axillary artery with the percutaneous procedure at the left axillary artery location. So at first we super selective cannulate the SMA, and then we cannulate the celiac artery, and then we put in the, after we put in the self-expandable stent graft, and we super selected the right renal and the left renal artery, and then put in the stent graft. And finally, we put in the distal extension abdominal stent graft. And then finally, we can percutaneous close the axillary artery. So the whole procedure time was about 364 minutes, and the floral time was about 89 minutes. So this is all the planning procedure with celiac standing, SMA standing, right renal, and the left renal standing. We prefer to use the self-expandable cover stent because of the lengthy distance from the orifice of the visual artery to the branch. And we also like to use the balloon expandable bare metal stent at the gate to reinforce the gate, so prevent the so-called type 3C endoleak. And then this patient discharged from home after 5 days the procedure, and the renal function is preserved as the preoperative status. This is the post-op CT scan follow-up. You can see that it's a nicely exclusion of all the annular sac of this patient. Currently, in the endovascular repair for the complex thoracoabdominal aneurysm, as for the spinal cord protection, we use the so-called therapeutic spinal drainage because of we only put in the spinal drain if the patient developed the symptom of bilateral lower extremity paraparesis, and we try to perfuse the pelvic circulation as soon as possible. So we will take out the big sheaths and leave the small sheaths on board to perfuse the pelvic and the lower extremity. And we try to keep all the systemic blood pressure over 120 to 140 during the whole procedure. And we minimize the blood loss to keep the hemoglobin adequate at least 10. In our center, we did about total 8 cases in our hospital of the T-branch graft, and there's no 30-day mortality, and the follow-up months from 3 to 43 months is in no midterm mortality. And we had a 2-stage procedure in 2 patients, and one is intentional stage 1, and the one is the unintentional stage because of the difficult to cannulate the renal artery. And 2 patients developed the immediate post-op the paraparesis, but improved after the therapeutic spinal drainage. And there is no endoleak in the CT scan follow-up. And we don't see any later visual artery occlusion. And only one failed renal artery consideration, and then did the renal artery bypass for that patient. This is currently how we did to do the modified percutaneous axillary cannulation. We pretty much cannulate at the segment 3 of the axillary artery, so we can do the percutaneous closure. Comparing to our previous incision, this is really need to open the axillary and sewing the graft to do the axillary cannulation. And this is how it looks like after the percutaneous closure. And currently, in our complex thoracoabdominal aortic annular repair, we pretty much use the onlay fusion and the combing CT to help us to orientate, cannulate the celiac branch, and also to decrease the radiation exposure with this complex aortic annular repair. And this is the paper that from the Dr. Tenoria. So their conclusion was that the evolution with this FIVA or branch EVA procedure with this advanced image application and the onlay fusion and the combing CT can really decrease the operator and the patient radiation exposure. And the combing CT after the procedure can immediate assessment and identify the intraoperative technical problem and leading to immediate revision and avoid the early secondary intervention. And this is the outcome, midterm outcome from this complex aortic annular repair for the endovascular, total endovascular technique. So this is a mean 430 patient receive all this either the T-branch or patient-specific company manufactured devices. So the conclusion of the paper is that the midterm result of all these complex aortic annular repair endovascularly had a high technical successful rate and low mortality and low rate of major adverse events and a high freedom rate of from the LD-related mortality. So in our center, we used to do the only open surgery, then we shift to hybrid repair, and in this decade, that we can do that all the total endovascular repair with the advanced image application to give a patient with better outcomes and complete anatomical correction and less procedure for the patient. Thank you for your attention.
Thank you much, Professor Awu, for sharing the technique of the open hybrid and FIVA and TIVA and also the three-branch techniques to treat the complex thoracoabdominal aneurysm. The next topic I would like to invite Dr. Thanakom Premapha. He's a vascular surgeon from Songkhla Nakharin Hospital. On the topic of on-the-table fenested TIVA with type B aortic dissection with unfavorable landing zone. Professor Thanakom, please.
Thank you, Mr. Chairman, and thank you for the organizing committee to allow me to share our experience and our perspective in Songkhla Nakharin Hospital. As you all know that normally there are more than one way to skin the cat. That means we can have more than one way or more than one method to do the things. And every one of us have their own way, preferred way or prefer way to do the method. Same as when we face with the type B aortic dissection, we need to cover the zone 2. We have a lot of options to deal with this problem. The first one that is about to cover the left subclavian. This is I think it's only can use in emergency situation which maybe can have a risk of stroke. But I think for the type B dissection, one thing that we should think about is this is the degenerative disease. We tend to have to bring patient come back and stent the whole aorta in the future. So if we cover the left subclavian now, that might be increased risk of spinal cord ischemia in the future. And the next option is about hybrid procedure. I think this is the standard practice in our hospital. Most of the patients we treat by this method, and we maybe have a little bit concern about minor complication about hematoma, lymph leak, or maybe nerve injuries. For the chimney left subclavian, interestingly, this option have very long time, but it cannot gain its popularity. But this is just have a study, comparative study between Curtis subclavian bypass and chimney left subclavian. The paper said that is effective, comparable effective with Curtis subclavian bypass may have a little bit high about the minor complication. The next one is about the arch branch or arch fenestration. I think this is like a Tesla that we want to have, but not everywhere can lead to this option. But if we can choose it, I think this is the one that really interesting. And then come to our our topic today about on the table venous type B in thoracic aortic dissection. Let's show you, this is the first patient. As you can see, the dissection, if to gain the good result, we have to cover the left subclavian, and you can see that there are lengths between the left common carotid and left subclavian. We start by deploy this variant stent graft a little bit and measure the length from the left common carotid to left subclavian and mark the size of the left subclavian fenestration. We make the hole and reinforce the hole, and this is what it looks like. On the procedure, we bring the long sheet from the brachial approach to mark the orifice of the left subclavian orifice. I think this is a very straightforward procedure because we have the long sheet to mark the position of the left subclavian artery, and then we partially deploy the stent graft, then cannulate into the fenestration. And after that, after we can get into the fenestration, we completely deploy the T-wire and then insert the balloon expandable stent. And this is if we want to make sure that it is in the fenestration, it is in the thoracic stent already, maybe we can rotate the C-arm a little bit 90 degrees to IO view. In this view, we can make sure that it is in the fenestration already. And this is the final result, and we follow her for 3 years already, and the stent graft is still good pattern. This is another one, same as the previous patient. Have the length between the left common carotid and left subclavian. After we bring the stent up and identify the tear size, the left subclavian orifice, and then start to partial deploy. With partial deploy, we have space between the aortic stent and the aortic wall, so we can have manipulate the wire and catheter into the fenestration. And this is the result after we follow him for 3 years already. This is about the proximal seal zone. What about if we have to deal about at the distal seal zone, at the visceral part? I think the best choice is the custom-made device that we can order from the company, because in this situation we have to deal with the very small aorta, and we need precise deployment of the fenestration into the target vessel. And this is the result after we treat him chronic aortic dissection with the custom-made device, and we follow him for 3 years already, and everything look good. But if patient come to us in emergency situation and we don't have the time for order the device, this is a situation that we might think about the on-table fenestration or physical modified endograft. We don't have a chance to treat the patient with on-table fen yet. But I can tell you about one patient that she also have very small aorta. I think this case can be a surrogate of the situation that chronic aortic dissection maybe come to us in emergency situation. This patient, as you can see the anatomy, she has a very small aorta, small access, so she was denied from custom-made device from every company, and she come back to us again with the rapid expansion of the aneurysm and abdominal pain. So we need to do something to treat her. Our strategy is to use the on-table fen or PMEC with the variant. Again, we plan to do 3 fenestration endograft for the SMA and both renal arteries, and we're going to occlude her celiac arteries. And this is how we measure the visceral organ. We use a multi-panel reconstruction and mark the SMA as the reference point, and then we measure from the SMA down to the this is the cross-axial view. The purple line is the level of the linear artery, and then we measure from subclavian to linear artery. And and from the left side, so we can know the length, the distance from the SMA to the linear artery from both sides, and then we measure for the cock position, the position that the visceral part come out by divide the whole aorta with 360 degrees, so 1 hour on the clock is about 30 degrees. In this case, you can see that the SMA come out at the 1 o'clock, and the right renal come out at the 10 o'clock, and the left renal come out at the 4 o'clock. When we have this distance and clock position, we know where we should to make a hole of fenestate on our graph. We use the same methods as we do on the left subclavian, partially deploy the stent graft, use electrocautery to make a hole, and then suture the wire or something to reinforce. That's what it looks like from SMA and both renal, and then we bring it back to the delivery system. For the material to use as a reinforce, we try many material. I think it's a leftover material that we have in our operating room, and there are different. We don't know yet what is the best for us. But I think V18, the tip of V18 or maybe command DS is good because we can clearly see where is it, and it's have a good shape. For the most left side, the concerto wire, we can easily see, but the shape of the fenestate is not good, and maybe sometimes it's difficult to cannulate into that. And we need 3 axes to secure the 3 fenestration to the visceral vessel before we can fully deploy. So we do 1 brachial puncture and axillary cut down for 2 sheath insertion. And we start by occlude the celiac trunk, then bring the device up, partially deploy, and identify this one is the fenestate of the SMA. As you can see, there are some space. So after we can cannulate and do the angiogram, we can identify the SMA. After that, cannulate into the SMA, exchange to the long sheath, bring the long sheath from the fenestate into the SMA that make this critical visceral branch secure. And after that, we continue to deploy, partially deploy. As you can see, because we don't have the reducing time, so we partially deploy first, so we have space between the fenestation and the target vessel on both sides. So even we deploy malposition a little bit, we still have a room for catheter and wire to manipulate to get into the target vessel. And then, as the same, bring the big long sheath in. After the long sheath already in, we fully deploy the whole aortic stent, and after that, we use balloon expandable tublet at the fenestration. And this is the SMA, this is the final result, and we flap her for 6 months already now. Everything looks good. So, in our perspective, I think on-table fenestration endograph is feasible option. But just because we can do it, it doesn't mean we should do it, because I think there are a lot of questions, a lot of what if happen, what if we cannot cannulate, what if a lot of many things we don't know the long-term outcome. So in our perspective, I think we should do this only when there are no other suitable options for our patient. Thank you very much.
Thank you very much. We have a little time for Q&A. Professor Wu, what do you think about this on-table fan? I heard that you also do it for the subclavian, right? You have
Yes,
any? Yes.
Yeah, thank you. I only did the the untable penetration for the subclavian artery because of in the arch pathology. I think you can do the gamma carotid or enamel fenestration also, but I think that for me, because the long-term durability is still very questionable for the on-site physician modified devices, and then I think for the long-term complication, the carotid and the enamel is much more severe and serious than the left subclavian artery. So before I really have the long-term outcome of the physician modified devices, I really hesitate to do it on the carotid or enamel artery. So I only do the cases with the left subclavian artery penetration, and technically it's not really difficult. And the other thing is that usually the distance between the enamel artery and the carotid left common carotid artery is really short. So you really don't get the benefit of doing the penetration to the left common carotid artery instead of doing both enamel and the left common carotid artery. That means that if you only do the left common carotid and the left subclavian, I think the benefit is really short. That instead of doing the 3-vessel penetration, so it's going to be very difficult for me to have the decision to put in the both brain vessel, the major brain vessel supplied to with the physician modified devices. Yes, and the visual artery, we only do couple cases that very rare with the penetration or the branch, but because the renal, I can really have the custom-made renal penetration devices, so I don't really bother to do the physician modified. And the renal, I think the chimney result is really equivalent to the penetration, so I don't think that will be my option. And the other thing is that in the cases that I show, that some cases you can just do the false urinary intervention, and also the fenestration tailor stent graft design to do the cases. And I think I still propose that in the no option patient, that for the endovascular, you still choose the open surgery instead of you try to do everything in the endovascular, but we always forget that open repair is still the gold standard. So I don't think that I don't really push myself to the limit of doing all the physician modified devices in the very, very complex cases.
Thank you. We have Professor Canard with us here too from France. It's very early in France. Thank you very much for joining us here. What's your opinion, Professor, for this PMAC or the on-table fan?
So it's something that we have started 6 or 7 years ago, and we were doing a lot of hybrid procedure for the aortic arch, and now we have moved to the on-table fenestration. So we started with large scallop for the LSA, and after we moved for single fenestration for the LSA, and now we are doing a lot of total endovascular repair of the arch. So we agree, we try to avoid to manipulate for zone 0 the brachiocephalic trunk and left common carotid artery, because we are concerned about the risk of stroke. Because if you use double branch for the arch, your risk of stroke is quite high, ranging from 15 up to 30% of stroke. So our strategy for zone 0 is to combine a large fenestration, which is like a scallop for a left common carotid artery and a left common carotid artery, and a single fenestration for the LSA. So it's something that we do on our daily practice now. And I was very interested by the presentation on the on-table fenestration, and something that we have changed in our practice now and have made the procedure much easier if we insert in the valiant tibia a preloaded wire. So we have a wire, we just have to catch it. So it makes the procedure much more simple, and there is no need to have deployed the graft in the arch, because with your preloaded wire, everything is already in place. So it's something that has changed a lot in our practice, but it's something that we do a lot. And regarding the durability, mean follow-up of the patient is now more than 36 months, so over 3 years. and we have never seen any stent fracture and things like that, because what the other physician and what we are doing, actually, we are doing the fenestration as performed by the company like Cook or other company which are doing the fenestration. So I think physicians are as able as an engineer to do a fenestration and reinforce the fenestration to have a long-term good outcomes.
Thank you. Thank you very much. Our panelists have any questions or comments?
So thank you. I have a question for Dr. Thanakom. So I think in PSU you have really excellent outcome of the chimney, even TIVA or EVA. So I would like to know when will you choose the chimney technique, or when will you choose the on-table fenestration in the patient which you have the criteria for these two techniques?
Yes, thank you for the question. I think this is a continue from yesterday. I think it depends on the pathology. If a patient have a juxtarenal, for me, if we have enough room for chimney, I think chimney EVA is safer. It's safer than on-table fenestration, because we can secure the target vessel before we can bring the aortic device up at the position. But sometimes when we have deal with the small aorta that not suitable for 2 or 3 chimneys, too crowded for put 2 or 3 chimney in that small aorta, that is the place for the on-table fenestration in emergency situation. But in elective case, I prefer to order the fenestration. For the disease that go beyond the juxtarenal or pararenal to maybe thoracoabdominal aortic aneurysm, I think the on-the-shelf device that we have today, such as T-branch or inside, that can cover 70-80% of the case already. So for the on-table fen, I think it's very limited indication for use. I'm going to use the off-the-shelf device first. And the next thing is about the situation, the health of the patient. If the off-the-shelf is not suitable for the anatomy of the patient and patient fit enough, I still think that I agree that open repair is still the standard of care, and we have to continue doing the open repair, because I think in the past 10 years, we pay attention on evolution of the stent graft, but also the open repair of the thoracoabdominal aortic aneurysm still evolve too. The result of the open repair, the result of the anesthesia is also improved. So I think it still be the standard of care for the open repair. So
what about the arch? What about the arch? You suggest chimney or not?
For me, as the same, it's an emergency situation or if in the emergency situation, I think maybe the arch, it depends on the vessel too. For the left subclavian, I think fenestate on table fenestate is not complicated, it's not that difficult. And compare between the fenestate and chimney, I think fenestate have a better result.
Yeah, so you prefer the on-table fen for the left subclavian better than the chimney of the left subclavian artery?
I prefer to do bypass.
Okay. No, let's say the bypass is not an option. We do the endo. Well, yeah, in our hospital we do mostly bypass, and then we do fen will be another option. I'm not sure, Professor Wu, Professor Kanal, you suggest chimney in the arch or not? That's too crazy to do it.
Yes. The thing is that for the annular cases, for the left subclavian revascularization, I still prefer to do the carotid subclavian bypass, because the thing is that the fenestration, the physician modified devices, it's still not like the custom-made devices that the fenestration hole can still have some leak from your bridging stent graft. So for the ignorant cases, I prefer to do the subclavian carotid subclavian bypass for the left subclavian artery revascularization. But for the dissection cases, I now hesitate to doing the left subclavian penetration, physician modified penetration, and putting the bridging the cover stent to the left subclavian artery. So for the left subclavian artery, now the chimney is less and less an option for me because of the choice of that doing the physician modified subclavian artery penetration. But for the carotid artery revascularization, I still prefer doing either the carotid bypass or the chimney procedure for the left carotid left common carotid artery instead of doing the penetration, physician modified penetration for the left common carotid artery. And for the innominate artery, I think for me that if my landing zone is going to reach the zone 0, I think I still prefer doing either the frozen elephant trunk instead of putting the current devices in the zone 0 area because I think the thoracic device, whatever you did, either the chimney, the 3 vessel in the arch, or you do the penetration, or you do the physician modified bridge devices, it's, as the Professor Katnut said, that the stroke rate is still too high, and the risk of the retrograde type A dissection is too high, and I think the device is still not suitable to land in the zone 0 area. So if I really need to go beyond the innominate artery, then I will choose the ascending aortic replacement with the frozen elephant trunk procedure for the patient.
Professor Kanat, what was your opinion on this?
So our experience is we have a different strategy. For example, we never use chimney because we don't rely on this approach. I think the fenestration is more reliable than the chimney. And our choice for zone 0 is mostly depending on the diameter of the ascending aorta. So if the diameter of the ascending aorta is over 40 millimeter, we avoid to land in zone 0, and we will prefer to do a frozen elephant trunk. But other than that, if the ascending aorta is less than 40 millimeter, we will go for a fenestrated graft.
Thank you very much. Well, thank you very much for Dr. Thanakom and Dr. Wu for joining us this morning. Dr. Kanat will still be with us. We will move on for the next lecture. The next one will be about the complications of this complex procedure. I'll start with the spinal cord ischemia in TIVA. Dr. Amarit Potikun will review the preventive strategies that we may have for this complex procedure that may lead to problems that we may face. Dr. Amarit is a cardiothoracic surgeon from the Department of Surgery, Chiang Mai University. Dr. Amarit, please.
Thank you, Chairman, panelists, and audience. And first, I will be thank you from my mentors, Dr. Swin, and to give me the chance to present on this honorable meetings. First, for the spinal cord ischemia, it can present intraoperative or post-operatively. And the mechanism of the spinal cord ischemia after the TIVA is ill-defined. The cause is maybe the direct coverage of the stent for the intercostal artery, or maybe from the hypotension during the operations, or the stent may be compromised the collateral segment of the spinal cord supply blood. And most importantly is the last one, the atherosclerotic part embolization from the wire when we manipulate, or the catheter when manipulate during the operations. So may have a review that the risk factor, the predictor for the spinal cord ischemia after we do the endovascular repair is the first one strongly is the length of the coverage of the stents. They have the study about the length more than 20 centimeters. It have the predictor of the spinal cord ischemia. And some factor like a previous abdominal surgery that will interrupt the collateral network of the spinal vessel. But it's not clear from the study is when we correlate of the artery of the Adam Kiewicz alone, we will not result in the private jet. It's not clear right now. And for the, not the predictor, is the lower 1/3 of the distal thoracic spinal network. It's not clear right now. The risk for the T1 from the meta-analysis, they found that the risk of the spinal cord ischemia is around 0 to 8%. And they found that endovascular versus the open repair, they have significant reduce of the mortality and reduce risk of the paraplegia when compared to the open surgery. We see the meta-analysis from many papers, we see that the risk of paraplegia is lower for endovascular repair than the open surgery. For the clinical presentation of the spinal cord ischemia, the hallmark of the presentation is the weakness of the lower extremities. The muscle stage can be presented by the paraplegia and paraparesis, which is the paraplegia is weaker than the gravity. The patient cannot move in more. The symptom of the presentations, the both lower limb may be paraplegia, but it's possible can occur by the unilateral weakness. It typically immediately after the surgery. But if they have a unilateral weakness, we must rule out the stroke because the stroke can present with just unilateral weakness, and we need to do CT to rule out the stroke than the spinal cord ischemia. The ischemia presentation may be different. We can classification into two types. The immediate is the ischemia occur after finish the anesthetic within 24 hours. And the delay is ischemia occur after the patient have normal presentation of neurological examinations after finish the anesthesia. The delay type can be present around 20 hours after after the patient have normal neurological exams. The incidence of the delay is much more than the immediate spinal cord ischemia. The pathogenesis of it is come from the spinal cord, but supply is deficit. They have interrupt of the oxygen supply via the spinal collateral network, or we use the scan. Or the scan of spinal collateral network can come from the cephalic central and the caudal. The cephalic main is come from the vertebral artery, which is the branch of the left subclavian. And the central input, it may come from the intercostal and lumbar artery, and the caudal is come from the iliac artery. The most important one is the artery of Adam-Kiewicz. They have a variation of the patient. Most of it, 75% is at the level of T9 to T12, and the rest of it in the lumbar regions. It's the last arterial medullary feeder of the spinal cord. But some studies show that when we cover the artery of Adam-Kiewicz, maybe not the cause or the risk factor of the spinal cord ischemia. And for the perfusions on the spinal cord, as on this equation is the difference between MAP and CSF pressure. So we can augment the spinal perfusion by increase the MAP or decrease the CSF pressure. So finally, the predictor for the spinal cord ischemia is come from the extent of the disease, the prior thoracic or abdominal surgery, the surgical sacrifice of the spinal segment, the aortic dissections, duration of aortic clamping that had not happened in the endovascular repair, and anemia, circulatory collapse, and systemic vasodilation during the surgery. For the recent study that published on the last year on the November from the Vascular Surgery Journal, they have the retrospective of the around 10,000 patients, and the 1,000 or around 8% have the previous infra-abdominal aortic repair. So they compare between the patient who do the infra-renal aortic repair with and without to compare each other. So the result, they found that the prior infra-renal aortic repair is not the predictor, not the strong predictor for the spinal cord ischemia. But the another risk factor like aortic dissections, the number of the stent graft to deploy, the unit of packed vessel used during the surgery is the main risk factor, not for the aortic prior aortic in the abdominal aortic repair before. So let's go to the spinal cord protection strategies. The aim is to preserve oxygen balance to the spinal cord. The strategy may be on around 5 strategies. For first, we do the minimize the ischemia by the minimize the interrupt of the spinal cord blood supply. For the endovascular repair, we have no aortic clamping, but we still have the stent to cover the spinal cord blood supply by cover intercostal or lumbar artery. So if we can use the range of the stent short as possible at the proper to the disease, it maybe reduce the interrupt of spinal cord blood supply. The second strategy is maximize the spinal cord perfusions. They can separate into 5 rules. So the first one is management of the segmental arterial blood supply. They can find that for the TIVA, after do the endovascular repair, some we have endoleak type 2. Endoleak type 2 is the retrograde blood supply into the sacs. So they decrease the perfusion pressure in the scan, in the spinal cord arterial network. So endoleak type 2 may be decreased, but it's not the main risk factor for the vessel cord ischemia, but it's the main risk for the rupture in the future. The second one is augmentation of the systemic blood pressure. If we raise the MAP, the spinal cord perfusion pressure is will be increased. So the recommend is maintain the MAP around 80 to 100 millimeter mercury. And maybe sometime we require vasopressor therapy during the operations. And the third one, we decrease the CSF pressure during the surgery by the, maybe we use the lumbar drainage before the surgery. So yeah, this one is use the lumbar drainage for the drain CSF to decrease the CSF pressure. We put the catheter on the percutaneous pre-operatively or post-operatively around the L3 or L4 lumbar interventions. And during the monitoring for the SCP, monitor hourly and maintain the SCP around 10 millimeter mercury. And if it elevates, we can drainage around 5 to 10 millimeters to reduce the CSF pressure. If the CSF pressure is drained too much or much more than 150, we can clamp to not to release it too much because they have a complication like subdural hematoma. The indication for CNF drainage in the endovascular repair patient is the when we put the endograft into the lower level around T9 to T12. Second, the long segment, we use the stent length more than 20 centimeters. And the compromise the collateral pathway like we have the previous abdominal aorta repair before. Or fourth one, the patient have the symptomatic of the spinal cord ischemia during the operation with prior lumbar drainage to do the operation before. And the last one is the extensive aneurysmal disease. For the fourth of the strategy is the left subclavian bypass. So the left subclavian is the main band for the vertebral artery. If we bypass the subclavian bypass or do the translocation, we increase the spinal network supply. And the last one for the second strategy is preconditioning for the paraspinal collateral network. They have some study that they call embolization one of the intercostal artery before the surgery. And after that, they found that the spinal collateral network is more vessel than the normal to prevent the spinal ischemia after we do the surgery. The third strategy is do the hyperthermia. Yes, in the open repair, we use the hyperthermia when we do the operation for the aneurysm, but in the endovascular repair, they have some paper to do the epidural cooling. This is the paper from the anesthesiologist. They do the spinal cord cooling via the epidural cooling by the lumbar drainage. They have some found that they have decreased the spinal cord ischemia after that. The fourth strategy is used for the pharmacological neuroprotections. They have many drugs to use to reduce the spinal cord ischemia, but mainly most widely adopted is used for just only the steroid, but in another drug is no strong evidence of any drugs. They have some paper that use the entire epidural corticosteroid inject into the damma, inject into the spinal drainage. And found that the patient have decreased the spinal cord ischemia after use this technique, but they have widely used right now. And the last strategy is the most important one. that early detection of spinal cord ischemia is there occur. Intraoperatively, when we do the endovascular repair, sometimes we use the general anesthesia. The patient have no conscious. They have some monitoring like SSEP or MEP. That is the intraoperative neurophysiology monitoring that can detect the decrease of the neurological activations that can find the spinal cord ischemia. That the anesthesiologist used in the neurology surgery. They can apply to do when we want to detect the spinal cord ischemia. So after the spinal cord ischemia occur, we need to do the rescuation for prevent the paraplegia in the future. So intraoperatively, we need to increase the MAP more than 100 mm mercury, decrease the central CVP less than 12 because the CVP can refer to the CSF pressure. And we do the CSF drainage after we done the operation. And if we have preoperative lumbar drainage, we decrease the CSF pressure less than 15 mm mercury. For the Chiang Mai University experience, we do preoperative CSF drainage in the case that we use the long stent graft, extensive wisdom, or the case that will perform the endovascular repair on the lower thoracic regions. And we always do the bypass on the left subclavian every case in the case that the landing zone cover the left subclavian. And in the post-operative ICU, we raise the blood pressure of the patients, monitoring of the ICP pressure, and use the paraplegia monitoring, the ICU protocol for the nurse and the resident to detect the spinal cord ischemia and paraplegia. This is the number of the patient around 9 years on the TIVA experience. Most of the patients, we do the TIVA on the aneurysm case, and second one is chronic type B dissections. And we found the spinal cord ischemia same as the study before, around 2.5%. Thank you for your attention.
Thank you much for a nice summarize of the spinal cord protection strategy by Dr. Marit. The next will be the fatal complication that we should know and avoid. The topic is avoidance of the retrograde type A dissection during the TIVA in the type B dissection. Will be taught by the Professor Ludovic Canal from Montpellier, the southern part of France. Please correct me if I'm spelled wrong. Professor Canal, please.
So, ladies and gentlemen, I'm very happy to share with you our experience dealing with retrograde type A aortic dissection. So, thoracic TIVA is currently the first-line therapy for most of the condition of the descending thoracic aorta, and it's becoming more and more common for lesion of the aortic arch. The most severe complication after endovascular repair of the thoracic aorta is the incidence of retrograde type A aortic dissection. It has been associated with a low incidence but a high mortality rate. Some reports, the first one and the most important one was in 2009. It was from the European Registry on Endovascular Aortic Repair, and they reported 63 cases of retrograde type A aortic dissection among nearly 5,000 cases of TIVA. And they pointed out the use of proximal bar stent as a risk factor of thoracic stent graft retrograde dissection. However, at this time in Europe, the most common stent graft use was the Talent stent graft. And they were not able to report the ratio of bar stent versus non-bar stent. So we thought that we should do a study to assess the risk factor of retrograde type A aortic dissection. So what we have done, we have used the Mozilla database. It's a database using 5 prospective trials, and we have combined this Mozilla database with the systematic review using the price-mile guideline. And we have made a pooled analysis of the systematic review combined with the Mozilla database. So the Mozilla database included 1,000 patients, 16 of them had a retrograde type A aortic dissection. The systematic review, we were able to include 51 series, and 174 cases of retroaortic aortic dissection. So, the results, we were able to include nearly 10,000 patients treated by TIVA for various lesions of the aortic arch and the descending thoracic artery. The incidence of retroaortic aortic dissection was 1.7%. So this is clearly an uncommon complication. Regarding the timing, most of the cases are reported before day postoperative 13th. It's intraoperative in 20% of the case and 70% before day postoperative 13th. Cases have been reported more than 3 years after the initial procedure. Regarding the outcome, the 30-day mortality of this devastating complication is over 33%. Regarding the risk factors, so we have made a univariate and multivariate analysis of the risk factor of retroaortic aortic dissection. And of course, we have assessed the risk of the proximal stent graft configuration, bar stent versus non-bar stent. And clearly, there is no difference in terms of incidence of retroaortic aortic dissection if you use a stent graft with or without a bar stent. A very important factor was the oversizing. The oversizing, we have made a logistic regression, and we clearly saw that the risk of retroaortic aortic dissection was associated with oversizing. Above 9%, each time we were increasing the oversizing by 1%, we increased the odds ratio by 1.1. The indication of TIVA was also strongly linked to the risk of retroaortic aortic dissection. If you treat a patient for an aortic dissection compared to a degenerative aneurysm, you have a 4 times higher risk of retroaortic aortic dissection. And this is even more true if you treat an acute aortic dissection. The risk of retroaortic dissection is 8 times higher for an acute aortic dissection compared to a degenerative aneurysm. Regarding the landing zone, the incidence was also linked to the proximal landing zone of the stent graft. If you treat a patient on zone 0, you have almost 7 times higher risk of retroaortic aortic dissection, and for zone 2, it's 4.3 compared to zone 4. So, of course, this systematic review has some limitation, lack of uniform reporting standard, included in the systematic review. So what can we say? This is clearly an uncommon complication, 1.7, but associated with a high mortality risk, and most of the time it's discovered before day postoperative 30th. What are the risk factors? The fragility of the aortic wall, especially if you treat an acute aortic dissection, you have an 8 times higher risk of retroaortic aortic dissection. There is clearly no impact of the proximal stent graft configuration with or without bar stent. Other factors are excessive oversizing and proximal landing zone in zone 0 and zone 2. We have also done an anatomical study on the factors of retroaortic aortic dissection. So we went through our hybrid procedures that we performed for arch repair, and we have included patient treated for aortic arch aneurysm, type B aortic dissection, and traumatic repair. So among these 42 cases, 5 of them experienced a retroaortic aortic dissection. So what we have done, we have been through the CT scan before and after the endovascular repair, and we have measured the aorta, measured the sinus of Valsalva, the sinotubular junction, and we have tried to see if there were some anatomical factors of retroaortic aortic dissection. So female gender had a higher risk of retroaortic aortic dissection. Regarding the endograft characteristic, if you treat a patient with an endograft of more than 42 millimeters, you have also a higher risk of retroaortic aortic dissection. Oversizing was also, in this study, strongly linked to the risk of retroaortic aortic dissection. Regarding the aortic morphology, in case of the loss of the sinotubular junction, as you can see on the CT scan, you have a higher risk of retroaortic aortic dissection, and aortic arch malformation was strongly linked to the occurrence of retroaortic aortic dissection. As you can see in this patient who had a right-sided aortic arch, she experienced a retroaortic aortic dissection. So what can we say? Malformation of the aortic arch, ascending aorta over 40 millimeter. It's what you can expect that when you are treating a patient with a 42 millimeter stent graft and the loss of the sinotubular junction. So regarding surgical conversion, in our initial experience, in 2014, we have reported 5 patients treated with surgical conversion. All of them were asymptomatic. We performed a replacement of the ascending aorta, reimplantation of the supraortic trunk, and the anastomosis was performed between the surgical graft and the distal stent graft without removing the stent graft. And all of them had uneventful postoperative course. So how can we prevent this complication? So in our policy, when we have to land in zone 0, we first have a look at the proximal of the diameter of the ascending aorta. If the diameter is over 40 millimeter, we know that this patient have a high risk of retrograde type aortic dissection. So now in our hospital, we perform a prophylactic replacement of the ascending aorta combined with the zone 0 debranching to allow the endovascular repair. Another thing is when the ascending aorta is less than 40 millimeter and you want to land in zone 0, we do rapid pacing during the side clamping of the ascending aorta to decrease the stress on the aortic wall and decrease this risk of retrograde type aortic dissection. One of the most important things in our hands is the choice of the oversizing. As we can see, the oversizing is strongly linked to the risk of retrograde type aortic dissection and linked to the indication for aortic repair. So when we use a stent graft, in case of acute type aortic dissection, we will go for an oversizing between 5 and 0%. For chronic dissection and degenerative aneurysm, our oversizing will be between 5 and 10%. So we choose the sizing according to the condition. We do not balloon if we don't have any type 1 endoleak during the procedure, and we just balloon if there is a persistent type 1 endoleak. So in conclusion, this is an uncommon complication associated with the fragility of the aortic wall. It's something that you will especially face in case of endovascular repair of aortic dissection, especially at the acute phases. Aortic morphology, malformation of the aortic arch, ascending aorta over 40 millimeter, and loss of the sinotubular junction are anatomical factor of retrograde type aortic dissection. So regarding the technical aspect, there is clearly no impact of proximal endograft configuration with or without a bar stand, and we should try to avoid oversizing as much as we can. Now we have experience, and we know that we don't need a very important oversizing to seal the lesion, and it's clearly a factor of stress on the aortic wall. How to prevent? Preventive replacement of the ascending aorta if you land in zone 0 and the ascending aorta is over 40 millimeter. We do rapid pacing for zone 0 debranching. We will advocate to moderate oversizing. We do not balloon if there is no type 1 endoleak. And in case of surgical conversion, we believe that there is no need to remove the stent graft to decrease the importance of the surgical conversion. Thank you for your attention.
Well, thank you very much. Now we are open up for Q&A session. Jamrit, please join us on the stage. Any questions from the panels? Yes, Jamrit, yeah.
Dr. Brent, your review is very true and I like it. I have a question. In the case after you do the operation after the TIVA and they have no spinal cord ischemia, how long do you keep the surface drainage?
Thank you for your questions. In the case, if we do the preoperative lumbar drainage, the anesthesiologist recommend that we keep around 24 hours to 48 hours after the operation because we say that we have the delay time of the spinal cord ischemia is occur the median time around 20 hours. So at least we keep around 24 to 48 hours after we done the operations.
Thank you. Thank you very much, Dr. Kanal. I enjoy your lecture a lot. May I ask your question? as everyone know, one of the risk factor of the retrograde type A dissection is TIVA in acute period. So about the uncomplicated type B dissection with the high risk features. So do you perform TIVA at that time, or you wait until the subacute period and perform TIVA later?
So in our strategy, as you can see, there is clearly a decrease in terms of risk if you wait. So our strategy is to wait at least 6 weeks before the preemptive TIVA. So far, we only treat patients who have high risk and have an aneurysmal evolution after the control CT scan, and we wait usually 2 months before treating them. And the best strategy to prevent is waiting, avoid the acute phases if there is no need to treat patients, and moderate oversizing. And we will go for a very low oversizing in this patient between 0 and 5%. So we know that a moderate oversizing is enough to seal the proximal entry tear because the intimal flap is not stiff and we can easily remodulate.
Thank you so much.
Professor Kanaut, you mentioned that one of the risk factors would be in zone 2 or zone 0. Let's say that we have a type B dissection and the main entry tear is maybe about 1 centimeter or maybe a little bit less, and distal to the left subclavian artery. If we land it, we cover left subclavian artery, go to zone 2. I'm not sure that the risk is higher. Is it okay that we accept a little bit shorter sealing zone in the acute type B dissection, that we have to treat it to avoid zone 2? I don't know, is that too much, or we still need a long coverage and go into zone 2? That's just one precaution factors.
So yeah, in our strategy, I think the landing zone is depending on the condition, and I think for an acute aortic dissection, a 15 millimeter neck is enough. But for other conditions like chronic dissection, degenerative aneurysm, I think 15 is not enough, and we will go for 20-25 millimeter necks because we want to have long-term durability. But if we have to land in zone 2, even in acute dissection, we will land in zone 2. We know that it's a little bit more risky because of the angulation of the neck, but we will play with the oversizing. That's what we do, but we can't shorter the proximal neck, otherwise we will have a massive type 1 embolic.
Professor Kanaut may have a question. For acute type B dissection, that we can land at the zone 2, but the ascending aorta is 4 centimeters. So what is your strategy or recommendation?
What we have seen about the ascending aorta diameter, we know that we perform a replacement if we have to land in the ascending aorta. Other than that, we know that it's still the best option to treat them. We know that we inform patients that they have a risk of surgical conversion, but we are not going to proceed an open replacement when we can try to do a TIVA. And it will be also all about oversizing. So even if the ascending aorta is over 40 millimeters, we treat them by TIVA, and we will have a CT scan before discharge to see what's going on. But it doesn't change our strategy. We know we are more cautious in terms of ballooning, sizing, and follow-up of this patient, but we are not going to shift to an open repair.
Okay. And at this moment, there are both bare stent and not bare stent in the market. So which configuration that you use in the acute type B dissection?
For all our patients, we use a bar stent. So we only use bar stent for everything because this study, we have been able to include 10,000 patients, and there is clearly no difference in terms of patient with or without bar stent. So our strategy is to treat all the patients, because my impression is that if you use a bar stent, it's like extending the proximal landing zone. First, you are more accurate during the deployment, you know exactly where you are going to land, and you will achieve, the graft will be more comfortable, and you will have some an extended proximal landing zone. So we use bar stent for all the patients.
And from the data that in the mother trial and the real world, it seems to be that the retrograde type A dissection in the mother trial is quite low, 1.6%, right? What
Yes.
is the reason behind that?
But I think we found the same outcome in all the studies that we have included, and it's 1.6. But you know, all these studies are more dedicated to the zone 2 and zone 3. So I think the risk of retrograde dissection is higher when you land more proximally in the arch. So that's why the retrograde dissection rate is very low. But I think as soon as you go further in the arch, the risk of dissection, especially if you land in zone 0, is really higher. So that's why I think in these studies the risk was low, but that's why we have to be cautious when we are going further.
I think well, thank you very much, Professor Kanaut. Thank you, Jan Amarit, for a nice session here. I think we will have more precautions about how we approach our patient to treat it. And I'm sure that this kind of cases is increased, and we have to deal with the cord ischemia or scare of concern of the retrograde type A dissection. So this session is very informative for all of us. Thank you very much for all panels and the speakers.